Hello and welcome to your ultimate guide for the HESI Exit exam. My goal today is simple: give you everything you need to fully understand the key concepts, master them, and walk into your HESI Exit exam with total confidence. In this video we'll cover emergency nursing, cardiac care, medication safety, respiratory management, clinical prioritisation. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website offers free exam guides and practice questions to help you ace your HESI Exit exam. You'll find the link in the description below, so be sure to check it out and get the resources you need to study smarter, not harder. So let's get started.
Question 1. The nurse is preparing the morning dose of digoxin for a client with chronic heart failure. The apical pulse is 52 beats per minute, and the client reports new onset nausea and reports seeing yellow halos around overhead lights. Which action by the nurse is most appropriate? Your options are: A. Administer the dose and document. B. Hold the dose, notify prescriber. C. Give half the prescribed dose. D. Recheck apical rate in 1 hour. Which one is it? Pause the video if you need more time. The correct answer is B. Hold the dose, notify prescriber. B is correct because bradycardia below 60, nausea, and visual halos are classic signs of digoxin toxicity. The nurse holds the dose and notifies the prescriber, so a digoxin level in potassium can guide the next intervention before more medication is given. A is wrong because administering digoxin when the apical rate is below 60 violates the standard hold parameter. Giving the dose during suspected toxicity will deepen bradycardia, worsen visual disturbance, and risk a life-threatening dysrhythmia in this client. C is wrong because adjusting a dose without a prescriber order is outside nursing scope of practice. Even a smaller dose adds drug burden to an already toxic client, and any change requires the prescriber's authorization first. D is wrong because waiting an hour delays recognition of toxicity that the assessment data already supports. The nurse must respond to the present findings rather than hope the apical rate will spontaneously climb into a safe range. Digoxin is one of the oldest cardiac drugs still in routine use, and it remains dangerous precisely because the line between therapeutic and toxic is razor thin. Understanding why that line is so narrow and what crosses it is the core of safe digoxin nursing. Digoxin works by blocking the sodium-potassium pump in cardiac cells. That blockade raises intracellular calcium, which strengthens myocardial contraction. The same mechanism slows conduction at the AV node by enhancing vagal tone, making bradycardia both a goal and the first warning sign that the drug is accumulating. When digoxin accumulates, it hits 3 systems simultaneously. Bradycardia signals AV node oversuppression. Yellow-green halos arise from identical pump inhibition in the retina. Nausea and anorexia come from stimulation of the chemoreceptor trigger zone in the brainstem. Seeing any one of these in a digoxin patient should prompt the others to be searched for immediately. Toxicity often arrives without any dose change at all. 4 factors frequently tip a stable patient over the edge: worsening renal function, hypokalemia, concurrent loop diuretics that waste potassium, and the drug's inherently narrow therapeutic window of 0.5 to 2 nanograms per milliliter. Any drift in these variables demands reassessment. The practical safeguard is the apical pulse counted for a full minute before every dose. Hold the medication and notify the prescriber if the rate falls below 60 in an adult. That single step, paired with awareness of potassium and renal trends, is what prevents a therapeutic dose from becoming a toxic one. Question 2. A client admitted with acute pancreatitis lies curled in a fetal position and reports severe epigastric pain radiating to the back. Serum lipase is markedly elevated and the client is restless. Which intervention should the nurse implement first? Your options are A. Offer clear liquids with crackers. B. Apply a heating pad to abdomen. C. Insert a nasogastric feeding tube. D. Maintain NPO status with IV fluids. Take a second. Which answer would you pick? The correct answer is D. Maintain NPO status with IV fluids. D is correct because pancreatic rest through strict NPO status reduces enzyme stimulation, and aggressive intravenous fluid resuscitation prevents shock during the early inflammatory phase. This combination addresses the highest priority risks of acute pancreatitis before pain management or further diagnostic workup is initiated. A is wrong because any oral intake stimulates pancreatic enzyme secretion and intensifies the inflammatory process already underway. Even clear liquids release cholecystokinin that worsens autodigestion, prolonging recovery in the acute phase of the illness. B is wrong because surface heat offers minimal pain relief in pancreatitis and does not interrupt the inflammatory cascade. Intravenous analgesia paired with pancreatic rest accomplishes far more for this client than warmth applied to the abdomen. C is wrong because gastric feeding directly triggers pancreatic enzyme release in the acute phase. When enteral nutrition is later appropriate, the tube tip is advanced past the duodenum into the jejunum to bypass pancreatic stimulation safely. Acute pancreatitis is sudden pancreatic inflammation, most commonly triggered by gallstones or alcohol. Understanding what drives early tissue damage explains every first-aid treatment decision. Normally, the pancreas releases digestive enzymes into the duodenum in response to food. In acute inflammation, those enzymes activate prematurely inside the gland and begin digesting pancreatic tissue itself, a process called autodigestion. Anything that stimulates the gland to secrete more enzymes accelerates that destruction. The three pillars of early care are NPO status, aggressive intravenous fluid resuscitation, and pain control. NPO removes the food trigger so the inflamed gland can rest, a V crystalloid, often several liters in the first 24 hours, counteracts massive fluid third spacing into the retroperitoneum and protects organ perfusion. Opioid analgesia then addresses the severe epigastric pain that bores through to the back. You know resuscitation is on track when urine output is adequate, blood pressure stabilizes, and hematocrit falls. When nutrition eventually becomes necessary, the tube tip must be advanced past the duodenum into the jejunum. Gastric feeding would stimulate enzyme release and worsen autodigestion. Oral intake is only reintroduced after pain resolves and lipase trends downward. Every first-day decision in acute pancreatitis flows from one principle: stop stimulating the gland, restore circulating volume, and let inflammation settle. NPO plus IV fluids is almost always the correct answer when the exam asks what to do first. Question 3. The nurse is using SPA to call the prescriber about a deteriorating post-operative client. After stating situation and background, the nurse moves into the assessment portion of the framework. Which information belongs in the assessment step before the recommendation is offered? Your options are specific orders the nurse wants. B. Time of the next scheduled dose. C. Vital sign trend and exam findings. D. Client's relationship to family members. Before I reveal it, which one do you think is right? The correct answer is C. Vital sign trend and exam findings. C is correct because the assessment portion of SPA conveys the nurse's clinical interpretation of what is happening, including vital sign trends and focused exam findings. The recommendation step that follows then proposes specific actions such as bedside evaluation or additional orders. Is wrong because requested orders belong in the recommendation step, which always follows assessment. Inserting them earlier weakens the framework that helps the prescriber visualize the picture before deciding what to change for the client. B is wrong because routine medication timing is background data rather than the clinical synthesis assessment provides. The prescriber needs the nurse's current interpretation of what is changing, not scheduling details from the medication administration record. D is wrong because family relationships rarely belong in the SPAR assessment step during a deterioration call. These social details support psychosocial planning but distract from the time-sensitive clinical synthesis the assessment step is designed to deliver. SPAR is a structured 4-step framework that compresses clinical information into a usable picture in under a minute. It was adapted into healthcare from the United States Navy Submarine Service, where high-stakes communication under pressure had been refined for decades. The 4 steps are situation, background, assessment, and recommendation, and their order is deliberate. Each step builds on the last, so the receiver hears the full clinical picture before any action is requested. In practice, situation names the client and the acute problem in one sentence. Background frames the relevant history. Assessment is where the nurse interprets what the data mean. Vital sign trends, exam findings, and clinical judgment. Recommendation names the specific action requested. The most common trap is conflating assessment with recommendation. New nurses tend to lead with what they want and then justify it. SPAR reverses that order on purpose. The receiver hears the picture first and reaches the same conclusion independently, which makes the recommendation feel like confirmation rather than a demand. Unstructured communication is a documented source of patient harm. SPAR replaces a vague phone call with a recognized script, reducing the clarifying questions that waste critical time during a deteriorating event. Question 4. A client with chronic obstructive pulmonary disease is receiving oxygen at 2 liters per minute by nasal cannula. The pulse oximeter reads 90% and the client is alert, comfortable, and free of distress. The home baseline saturation documented last visit was 91%. Which action by the nurse is most appropriate? Your options are A. Maintain current flow and monitor. B. Titrate oxygen up to 98%. C. Apply a non-rebreather mask immediately. D. Discontinue oxygen because saturation is stable. What's your answer? Commit to one before I continue. The correct answer is A. Maintain current flow and monitor. A is correct because saturations of 88 to 92% are acceptable in chronic carbon dioxide retainers because excess oxygen suppresses the hypoxic respiratory drive. The current reading matches baseline, so maintaining the prescribed flow and trending the value is the appropriate action. B is wrong because titrating oxygen toward 98% in a chronic retainer suppresses the hypoxic drive that keeps the client breathing. The resulting carbon dioxide narcosis can lead to somnolence, hypercapnia, and progressive respiratory failure. C is wrong because a non-rebreather delivers very high oxygen concentrations that would overshoot the acceptable target range entirely. Such aggressive escalation is reserved for severe hypoxemia or impending respiratory failure, neither of which is present. D is wrong because abruptly discontinuing supplemental oxygen invites desaturation below the acceptable threshold for this client. Maintaining the prescribed flow keeps the saturation within range. Removal would destabilize the client without clinical benefit. In advanced COPD, the lungs chronically retain carbon dioxide, and the brainstem's respiratory control center adapts in a critical way. Understanding this shift explains why standard oxygen targets do not apply to these patients. Normally, a rising carbon dioxide level is the primary signal to breathe. In chronic retainers, that response is blunted, and a falling oxygen level becomes the dominant drive instead. This is the hypoxic respiratory drive. and flooding these patients with high-flow oxygen can silence it entirely, sending them into respiratory failure. When supplemental oxygen raises the saturation too high in a retaining patient, the hypoxic drive is suppressed. Respiratory rate falls, alveolar ventilation drops, carbon dioxide builds further, and the patient can progress rapidly to somnolence and respiratory arrest. The accepted saturation target for a known carbon dioxide retainer is 88 to 92%. The lower bound prevents tissue hypoxia. The upper bound protects the hypoxic drive. Titrating above 92% is unnecessary and risks the very complication oxygen was meant to prevent. In practice, start low, 1 to 2 liters by nasal cannula, and titrate just enough to reach the target range. Recheck saturation after every adjustment and watch mental status and respiratory rate closely. When a retaining patient looks comfortable and their saturation matches their documented baseline, the right action is to maintain the current flow and monitor. Question 5. The nurse is admitting a client to the inpatient psychiatric unit on suicide precautions. On entry, the client is wearing a leather belt, sneakers with shoelaces, and a hooded sweatshirt with a drawstring. Which action by the nurse is the priority? Your options are: A. Allow the client to keep belongings. B. Document the items in the chart. C. Remove and secure all ligature items. D. Ask whether the client plans self-harm. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Remove and secure all ligature items. C is correct because standard inpatient psychiatric admission requires removal of belts, shoelaces, drawstrings, and other ligature risk items before the client enters the milieu. These items pose immediate environmental risk on a behavioral health unit and are stored securely for return at discharge. A is wrong because allowing ligature risk items violates basic environmental safety standards on a psychiatric unit. Personal property preferences yield to documented suicide precautions until risk has been reassessed and meaningfully reduced. B is wrong because charting alone does not address the immediate environmental hazard sitting on the client. Noting that the client wore a belt while leaving the belt accessible would constitute negligence if it were later used. D is wrong because verbal screening does not substitute for removing access to lethal means. The nurse must control the environment whether or not the client volunteers intent at this moment of admission to the unit. When a client at risk for self-harm is admitted to a psychiatric unit, the first priority is environmental safety, not verbal screening, not charting. This principle is grounded in decades of suicide prevention research. Research shows that most suicide attempts are impulsive, and the lethality of an attempt depends heavily on what means are available in that moment. When countries switched from coal gas to natural gas, overall suicide rates dropped because people who lost access to that method did not simply find another. The same effect holds for firearms restrictions, pesticide bans, and bridge barriers. A ligature item is anything that can form a noose or be wrapped around the neck. On admission, the nurse removes and secures belts, shoelaces, hoodie drawstrings, long necklace chains, neckties, scarves, and electrical cords before the client enters the unit. The sequence matters. Environmental control always comes first. Remove and secure ligature items. Document the inventory with chain of custody, and only then complete the in-depth assessment of intent, plan, and protective factors. Verbal assessment is unreliable in an acute presentation, and the danger is present in the room regardless of what the client says. On exam day, when you see phrases like suicide precautions, ligature, lethal means, or a list of items the client is wearing, the priority action is always to remove and secure those items first. Documentation and verbal screening follow only after the environment is safe. Question 6. The nurse is teaching a client who was recently prescribed sertraline for major depressive disorder. The client mentions plans to add Saint John's wort because a friend recommended it for low mood. The client also takes acetaminophen occasionally. Which response by the nurse is best? Your options are: I add the herb, it is safe. B. Take the supplement only on weekends. C. Stop sertraline before adding the supplement. D. Avoid the herb. Serotonin syndrome risk. Which would you go with? Lock it in before the reveal. The correct answer is D. Avoid the herb. Serotonin syndrome risk. D is correct because St. John's wort has serotonergic activity, and combining it with a selective serotonin reuptake inhibitor can precipitate serotonin syndrome with agitation, tremor, hypothermia, and autonomic instability. The client should avoid the supplement and clear any new herbal with the prescriber. A is wrong because reassurance that the combination is safe ignores the documented risk of serotonin syndrome from combined serotonergic agents. False reassurance from the nurse could send the client into a potentially life-threatening drug reaction. B is wrong because timing the supplement to weekends does not prevent additive serotonergic activity. Serotonin syndrome can develop after a single combined dose, regardless of which day of the week the supplement is taken. C is wrong because abruptly stopping a selective serotonin reuptake inhibitor causes discontinuation syndrome and risks relapse of depression. The correct plan is to avoid the dangerous supplement rather than abandon the antidepressant that is helping the client. Serotonin syndrome is a drug-induced emergency caused by excessive serotonergic activity in the brain and body. It can occur when two serotonin-elevating agents are combined, even if one of them is herbal and sold over the counter. SSRIs like sertraline work by blocking the serotonin reuptake transporter, raising synaptic serotonin levels. John's wort does the same thing. When both are taken together, reuptake inhibition stacks on top of reuptake inhibition, flooding the synapse and pushing serotonin into a dangerous range. Recognition depends on the classic triad: mental status changes such as agitation and confusion, autonomic instability including tachycardia, hypertension and hypothermia, and neuromuscular hyperactivity, most distinctively clonus, hyperreflexia, and tremor, often more prominent in the lower extremities. John's wort is widely available without a prescription and marketed for mild depression, giving it a false sense of safety. Pharmacologically, it inhibits serotonin and norepinephrine reuptake and also induces cytochrome P450 enzymes, altering the metabolism of many prescription drugs. When a client on an SSRI mentions adding St. John's wort, the correct nursing action is clear. Advise them to stop the herbal product, review warning symptoms like tremor, sweating, and racing heart, and ensure the prescriber is notified before any new supplement is added. Question 7. The nurse pulled hydromorphone 2 mg from the automated dispensing cabinet, but the ordered dose is 1 mg. Another licensed nurse is available, and the unit policy specifies witness disposal at the point of preparation. Which action by the nurse is most appropriate for the leftover controlled substance? Your options are: A. Save the extra for a later dose. B. Discard the remainder in regular trash. C. Waste remaining milligram with a witness. D. Flush the unused medication down toilet. Don't overthink it. Which one feels right? The correct answer is C. Waste remaining milligram with a witness. C is correct because federal regulations require controlled substance waste to be witnessed by a second licensed nurse and co-signed by both. Wasting at the point of preparation prevents diversion, supports accurate inventory counts, and protects both nurses from later accountability questions. A is wrong because saving leftover controlled medication creates an unsecured supply that can be lost, diverted, or used outside proper documentation. Each new dose must be drawn fresh from the dispensing system rather than from saved remainders. B is wrong because discarding a controlled substance in regular trash violates federal record-keeping and disposal requirements. The medication could be retrieved by unauthorized persons and offers no witnessed accountability for the unused portion. D is wrong because flushing controlled substances introduces them into wastewater and contaminates the local water supply. Current Drug Enforcement Administration guidance discourages flushing in favor of approved on-site deactivation or witness disposal systems. When a nurse draws more of a controlled substance than is ordered, the leftover must be properly wasted, and the rules governing that process are stricter than for any other class of medication. A second licensed nurse must witness waste to prevent diversion, the theft of controlled substances from patients, often for personal use. The witness creates an audit trail that is difficult to falsify and shields the wasting nurse from later accusations. At the moment of preparation, the nurse draws the ordered dose, locates a second licensed nurse, and physically disposes of the remainder into an approved denaturing waste container, not a sink, trash, or toilet. Both nurses co-sign the electronic record immediately, not later. For example, a 2 mg hydromorphone syringe is pulled for a 1 mg order. 1 mg is drawn for the patient, and the remaining 1 mg is wasted into the denaturing container while the witness observes. The entire event, disposal and co-signature, is completed at the bedside in under 2 minutes. Saving a partial dose for later is diversion regardless of intent. Each leftover belongs to that medication event and must be wasted then and there. The witness must be a licensed nurse, not a technician or clerk, and documentation cannot wait until the end of the shift. Question 8. An adult client with decision-making capacity has just received a new cancer diagnosis from the oncologist. The client asks the nurse to keep the result private while taking time to think. Family members in the hallway are asking the nurse for the result. Which action by the nurse is most appropriate? Your options are A. Tell family because they need closure. B. On a request, inform the care team. C. Direct family to ask the provider. D. Document result and notify all family. Got a guess? Lock it in. The correct answer is B. On a request, inform the care team. B is correct because under HIPAA, the client controls disclosure of personal health information. The nurse honors the client's express preference, documents the wish for privacy, and communicates it to the care team so no staff member inadvertently shares the diagnosis with family. A is wrong because disclosing protected health information to family without the client's authorization breaches HIPAA. Acting on what the nurse perceives as the family's emotional need does not override the client's legal right to controlled disclosure. C is wrong because redirecting the family to the provider still risks unauthorized disclosure of the diagnosis. The provider faces the same HIPAA constraint and would only release information the client has expressly authorized for release. D is wrong because documentation is appropriate, but notifying the family directly contradicts the client's expressed wishes. The correct documentation records the privacy preference, so every staff member protects the information moving forward. HIPAA, passed in 1996, established federal protections for patient health information. At its core, the law codifies a principle that has guided healthcare ethics for centuries. Confidentiality is the foundation of the therapeutic relationship. A client with decision-making capacity is the gatekeeper of their own clinical data. This includes diagnoses, lab results, treatment plans, and progress, and critically, who receives that information, including family members. Capacity has 4 components: the ability to understand information, appreciate how it applies personally, reason through alternatives, and communicate a stable choice. An adult who meets all 4 retains full control over their privacy. Regardless of diagnosis severity or family involvement, there are narrow exceptions where mandatory reporting laws override patient privacy. These include child or elder abuse, certain communicable diseases, gunshot wounds, and credible threats against identifiable third parties. Outside these carved-out categories, the client decides. When a capable adult asks you not to share information, even with a supportive family member, you honor that preference and document it. A spouse or adult child has no automatic right to clinical information. The client's expressed wish is the legal and ethical standard. Question 9. A client with a T4 spinal cord injury sustained 6 months ago suddenly develops a pounding headache, flushing above the level of injury, and a blood pressure of 210/116. The skin below the lesion is cool and pale. Which action should the nurse take first? Your options are: A. Place client flat with legs elevated. B. Administer subcutaneous insulin promptly. C. Apply a cooling blanket and dim lights. D. Sit upright, assess for bladder distension. Which one is it? Pause the video if you need more time. The correct answer is D. Sit upright, assess for bladder distension. D is correct because these findings indicate autonomic dysreflexia, a sympathetic surge triggered by a noxious stimulus below the lesion. Sitting the client upright uses gravity to lower blood pressure while the nurse simultaneously identifies and removes the trigger, most commonly a distended bladder. A is wrong because shock positioning increases venous return and drives blood pressure even higher during dysreflexia. Elevating the legs during a hypertensive surge raises the risk of stroke and intracranial hemorrhage in this client. B is wrong because insulin lowers serum glucose rather than blood pressure and has no role in autonomic dysreflexia. Confusing the two emergencies wastes critical minutes, while the hypertensive crisis continues to threaten end organ injury. C is wrong because environmental adjustments do not interrupt the sympathetic reflex driving the crisis. The hypertension persists until the noxious stimulus is located and physically removed, so cooling the room solves nothing essential. Autonomic dysreflexia is a life-threatening emergency unique to spinal cord injuries at T6 or above. Understanding the mechanism, why it happens and how the body responds, is the key to recognizing and stopping it fast. Any noxious stimulus below the level of injury can set off the cascade. The reflex fires normally, but the damaged cord blocks the brain's inhibitory signals, so an unchecked sympathetic surge drives blood pressure dangerously high within seconds. Below the injury, intense vasoconstriction drives blood pressure upward and leaves the skin pale and cool. Above the injury, the intact vagus nerve triggers a parasympathetic response. Bradycardia, flushing, sweating, and a pounding headache from cerebral vasodilation. The same body shows two opposing pictures at once. The first action is always to sit the client upright, so gravity reduces cerebral venous pressure. Next, identify and remove the trigger, caseis emergentes. Check the catheter for kinks first, then the bowel, then clothing and pressure points. Only if pressure remains critically high after the trigger is removed should a fast-acting antihypertensive be given. Don't confuse autonomic dysreflexia with spinal shock or orthostatic hypertension. Both affect the same population but cause hypertension, not hypertension. Dysreflexia is a chronic phase emergency defined by massive hypertension from a removable noxious stimulus. Remove the trigger and the pressure falls. Question 10. An older client with type 2 diabetes is admitted with a blood glucose of 980, severe dehydration, and minimal urinary ketones. Serum osmolality measures 348, and the client is confused and lethargic. Which condition does the nurse suspect? Your options are A. Rebound from acute hypoglycemia, B. Hyperosmolar hypoglycemic syndrome, C. Syndrome of inappropriate antidiuretic hormone, D. Diabetic ketoacidosis with compensation. Take a second. Which answer would you pick? The correct answer is B. Hyperosmolar hypoglycemic syndrome. B is correct because hyperosmolar hypoglycemic syndrome typically appears in older adults with type 2 diabetes and produces extreme hyperglycemia, profound dehydration, and elevated osmolality without significant ketosis. Treatment centers on aggressive fluid replacement followed by a carefully titrated intravenous insulin infusion. A is wrong because hypoglycemia produces glucose values below 70 with adrenergic symptoms such as diaphoresis and tremor. A reading near 1000 sits at the opposite end of the glycemic spectrum entirely from any low sugar emergency. C is wrong because syndrome of inappropriate antidiuretic hormone produces water retention with low serum sodium and low osmolality. The dehydrated, hyperosmolar picture here matches the opposite physiologic profile and rules that diagnosis out. D is wrong because diabetic ketoacidosis includes prominent ketonuria, fruity breath, and cosmal respirations from metabolic acidosis. Minimal ketones plus a type 2 background point clearly toward the hyperosmolar pathway rather than ketoacidosis. Hyperosmolar hypoglycemic syndrome, or HHS, is a serious acute complication of type 2 diabetes defined by extreme hyperglycemia, severe dehydration, hyperosmolar plasma, and minimal or absent ketosis. Understanding why it differs from diabetic ketoacidosis starts with insulin. In type 2 diabetes, residual insulin is enough to suppress lipolysis and block ketone formation, but not enough to control blood glucose. This is why glucose climbs slowly, sometimes over days, into ranges of 600, 900, or even above 1,000 milligrams per deciliter, without the acidosis seen in DKA. The two syndromes share hyperglycemia and dehydration but diverge sharply on pH, ketone level, and the degree of insulin deficiency. HHS is a disease of relative insulin sufficiency. DKA is a disease of near absolute insulin deficiency, most common in type 1 diabetes. Diagnosis requires meeting 4 laboratory criteria: plasma glucose above 600, effective serum osmolality above 320, an arterial pH above 7.3, and minimal or absent ketones. Rising osmolality shrinks brain cells, causing the mental status changes, confusion, lethargy, and at the extreme, seizure or coma. Treatment follows a strict sequence: isotonic saline first to restore volume, then a modest insulin infusion to lower glucose gradually, then aggressive potassium replacement, because insulin drives potassium into cells and can unmask a dangerous deficiency. Glucose should fall no faster than 100 milligrams per deciliter per hour to prevent cerebral edema. Question 11. The home health nurse is teaching a client with chronic low back pain about safe use of a heating pad. The client lives alone, has intact lower back sensation, and reports that warmth relaxes tight paraspinal muscles. Which instruction by the nurse is most appropriate? Your options are A. Apply heat 15 to 20 minutes. B. Sleep on the heating pad overnight. C. Use the highest setting for relief. D. Place the pad on bare skin. Before I reveal it, which one do you think is right? The correct answer is A. Apply heat 15 to 20 minutes. A is correct because heat therapy is applied for 15 to 20 minutes per session with a cloth barrier between the device and skin. This duration delivers vasodilation and muscle relaxation while minimizing burn risk, especially for clients using heat unsupervised. B is wrong because sleeping on a heating pad delivers continuous pressure and heat to one area for hours. The combination produces serious burns even with intact sensation because the protective response to discomfort is suppressed during sleep. C is wrong because the higher setting increases burn risk without delivering faster therapeutic benefit. Moderate heat over the permitted interval is safer and more effective than brief exposure to a temperature high enough to scald skin. D is wrong because direct contact removes the protective barrier that diffuses heat evenly across the skin. A thin towel between pad and skin reduces hot spots and dramatically lowers the risk of thermal injury during home use. Heat therapy is one of nursing's oldest tools, used for chronic muscle stiffness, low back pain, and menstrual cramps. Understanding the underlying physiology helps explain both why it works and how to apply it safely. Warming the skin causes local vasodilation, delivering oxygen and clearing inflammatory mediators from aching muscle. At the same time, heat decreases muscle spindle activity, reducing protective spasm, and competes with pain signals at the spinal cord. The result is looser muscle and a calmer pain experience. A single heat application should last 15 to 20 minutes. That window is enough to achieve vasodilation and the analgesic effect. Extending beyond 20 minutes triggers rebound vasoconstriction, skin adaptation, and risks a low temperature burn, even at settings that feel only warm. Every safe application uses a cloth barrier to slow and even out heat transfer, and a timer to enforce the duration limit. Heat is never applied over impaired sensation, open wounds, or active swelling, and clients must be able to remove the device themselves. Falling asleep on a heating pad is the most common path to a burn. Heat and cold are not interchangeable. Heat increases blood flow and is best for chronic stiffness and muscle spasm. Cold reduces inflammation and swelling and is preferred in the first 48 hours after acute injury. Switching the two reverses the intended physiology and can worsen the condition. Question 12. The nurse is teaching the parents of a 5-year-old scheduled for a tonsillectomy. The child is anxious and is asking many questions about what will happen. Which statement by the nurse is most developmentally appropriate when explaining the procedure to the child? Your options are: A. The doctor will cut out lumps. B. You may have postoperative discomfort. C. You will sleep with special air. D. You will sleep, then wake scratchy. What's your answer? Commit to one before I continue. The correct answer is D. You will sleep, then wake scratchy. D is correct because preschoolers think concretely and benefit from honest language that avoids frightening words like cut or shot. Comparing the post-op sensation to a familiar scratchy feeling lets the child anticipate the experience without triggering fears of body mutilation. A is wrong because words like cutout lumps trigger a preschooler's intense fear of body mutilation. Using clinical or violent vocabulary undermines trust and predictably worsens preoperative behavioral distress in this developmental stage. B is wrong because abstract phrases like postoperative discomfort exceed the cognitive level of a 5-year-old. Preschoolers need concrete, familiar reference points rather than medical terminology when learning what to expect. C is wrong because saying special air without explanation can frighten a literal thinker who imagines a strange substance. The statement also omits the post-op sensation, so the child is left unprepared for what follows surgery. When preparing a preschooler for a procedure, the nurse's language choices can determine whether the child stays calm or carries lasting fear. Preschool thinking is concrete, magical, and tied to the present. So standard clinical vocabulary can do real harm. 3 principles guide developmentally appropriate teaching. First, describe sensations a child will actually experience rather than clinical procedures. Second, replace frightening words with neutral equivalents. Cut becomes opening, shot becomes pinch, and put to sleep becomes special sleep. Third, offer small real choices to preserve the child's sense of control. Language substitution is the core clinical skill. Each frightening clinical term maps to a familiar, neutral equivalent the child can hold without distortion. The goal is honesty without the emotional charge of words that sound violent or final to a 3 to 5-year-old. Timing must also match development. Preschoolers cannot maintain accurate expectations over weeks. So teaching happens 1 to a few days before the procedure with a brief recap the morning of surgery. Younger children need parental presence more than words. Older children and teens tolerate and benefit from longer lead times. On exam day, when you see a preschooler, a scheduled procedure, and a question about the best nurse in response, look for concrete sensory language, neutral word substitutions, and at least one small choice offered to the child. Any option that uses untranslated clinical terms or skips preparation entirely misses the developmental target. Question 13. The nurse is teaching an older adult who will use a single-point cane after a left total knee arthroplasty. The client has full strength on the right side but fears falling at home. Which client statement indicates a need for further teaching about safe cane use? Your options are A. Cane goes in my right hand. B. Cane goes in my left hand. C. Cane and left leg move together. D. Strong leg leads going upstairs. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Cane goes in my left hand. B is correct because A cane is held on the strong side, opposite the weaker leg. After a left knee arthroplasty, the cane belongs in the right hand. The right cane and left leg advance together, followed by the unaffected right leg. A is wrong because placing the cane in the right hand is the correct technique for a left knee replacement. This statement reflects correct learning rather than a knowledge gap that would prompt further teaching by the nurse. C is wrong because moving the cane and the affected leg together is the recommended gait pattern. This pairing distributes weight off the surgical knee at the moment that limb makes contact with the floor. D is wrong because leading with the unaffected leg when climbing reflects the standard up with the good rule. The strong leg pulls the body upward, then the cane and weak leg follow safely behind it. A single point cane improves balance and reduces load on a weak or painful leg. The most tested concept is deceptively simple. The cane goes in the hand opposite the weaker leg, not the same side. This feels counterintuitive, but the biomechanics explain exactly why. In normal gait, the opposite arm and leg move together. When the right leg steps forward, the left arm swings forward. A cane on the strong side mimics this natural counter swing, letting the arm bear weight through the cane at the exact moment the weak leg lands. This creates a stable 3-point base at the moment of greatest load. The strong leg, the cane on the opposite side, and the weak leg all share the floor together, distributing weight safely instead of overwhelming the weak side. The gait sequence follows a consistent rhythm. The cane and the weak leg advance together as one unit. Then the strong leg steps forward past them. This repeats with every stride, keeping weight shared between the cane and weak leg during each vulnerable moment. On stairs, remember the mnemonic, up with the good, down with the bad. The strong leg leads going up and the weak leg and cane lead going down. The cane always stays with the weak leg in both directions, maintaining protection where it is needed most. Question 14. The nurse reviews morning coagulation results for a client on a heparin infusion for pulmonary embolism. The activated partial thromboplastin time is reported as 115 seconds, with a control value of 30 seconds today. Which action by the nurse is most appropriate? Your options are A. Continue the infusion at current rate. B. Increase the rate to reach target. C. Stop the infusion, notify prescriber. D. Switch infusion to oral warfarin now. Which would you go with? Lock it in before the reveal. The correct answer is C. Stop the infusion, notify prescriber. C is correct because therapeutic activated partial thromboplastin time during heparin therapy is 1.5 to 2.5 times control, roughly 45 to 75 seconds here. A value of 115 is supratherapeutic, so the infusion must be stopped. A is wrong because continuing heparin while the activated partial thromboplastin time sits well above the therapeutic ceiling exposes the client to hemorrhage. Maintaining the rate ignores the trigger to pause and recalculate the dose downward. B is wrong because increasing the rate drives the already supratherapeutic level further from safety. The result calls for de-escalation rather than amplification. Pushing harder converts a recoverable situation into a potentially catastrophic bleed. D is wrong because warfarin requires several days to achieve effect and would not address the immediate bleeding risk from current heparin excess. Switching agents in this moment ignores the active infusion that must be paused first. Unfractionated heparin is a fast-acting intravenous anticoagulant that works by binding antithrombin, dramatically speeding up its inhibition of thrombin and factor XR. Because its effect varies widely between patients, careful laboratory monitoring is essential. Heparin binds antithrombin and accelerates its inhibitory action against both thrombin and factor XR. This interrupts the coagulation cascade, preventing new clot formation and limiting extension of existing thrombus. The therapeutic APTT during heparin therapy is 1.5 to 2.5 times the lab control. With a typical control of 30 seconds, that means targeting roughly 45 to 75 seconds. Values outside this window guide the nurse to adjust the infusion rate up or down per the titration protocol. A critical exam distinction: unfractionated heparin is monitored with the APTT, while warfarin uses the INR with a target of 2 to 3. Low molecular weight heparins like enoxaparin and direct oral anticoagulants such as apixaban and rivaroxaban do not require routine laboratory monitoring. Matching the right test to the right drug is one of the most commonly tested nursing concepts. Heparin's rapid onset and short duration make it ideal for acute management. If the APTT rises dangerously and bleeding occurs, protamine sulfate reverses its effect quickly. Keep these relationships anchored and heparin questions become straightforward. Question 15. An older client reports pain at 6 out of 10 on the postoperative unit following hip arthroplasty. The client's face appears strained and the surgical leg is guarded carefully against the mattress. Which action by the nurse best honors pain is the fifth vital sign? Your options are A. Document the score, reassess later. B. Override the score with clinical judgment. C. Wait until vital signs change to medicate. D. Treat using the reported number now. Don't overthink it. Which one feels right? The correct answer is D. Treat using the reported number now. D is correct because self-report is the gold standard for pain assessment, and a score of 6 warrants prompt treatment. Reassessment timing depends on route, generally 15 to 30 minutes after intravenous analgesia, to confirm effectiveness and identify any opioid-related side effects. A is wrong because deferred reassessment ignores the client's expressed distress and observable behavioral cues. That schedule belongs to routine recheck of a treated client, not to the initial response after a moderate score has been verbalized. B is wrong because overriding the client's self-report with the nurse's intuition contradicts professional pain management standards. Subjective experience belongs to the client, clinical judgment supplements rather than replaces the reported numeric score. C is wrong because vital sign changes are unreliable surrogates for pain, especially in opioid-naive or older clients. Normotension and bradycardia can coexist with severe discomfort, so waiting for numbers to shift causes preventable suffering. Pain assessment in nursing centers on one foundational principle: pain is whatever the experiencing person says it is. Self-report is the gold standard, and no objective finding overrides a client's stated score. The reason self-report is primary is that pain is fundamentally subjective. Two clients with identical surgical incisions can rate their pain at 3 and at 9 on the same morning. Neither rating is wrong. Each reflects tissue injury, mood, attention, history, culture, and personal meaning, all integrated at once. The numeric rating scale, anchored at 0 for no pain and 10 for the worst imaginable pain, is the most widely used tool in adult care. Whichever scale is chosen, the same scale must be used consistently across reassessments so that trends remain interpretable. Reassessment timing is tied to the analgesic route. Intravenous opioids peak in 15 to 30 minutes, oral opioids around 60 minutes, and patient-controlled analgesia is checked each round. The new score is compared to the previous score, and side effects such as sedation and respiratory rate are evaluated before the next decision. Objective findings like grimacing or guarded posture are supportive data, but they never replace what the client reports. The nurse's role is always the same: accept the rating, intervene appropriately, and reassess on a timeline matched to the route used. Question 16. During a home visit, the nurse assesses an older adult's instrumental activities. The client cooks simple meals, manages medications, and answers the telephone but no longer balances the checkbook or drives independently. Which conclusion best summarizes this client's functional status? Your options are: A. Requires full nursing home placement. B. Has selective IADL limitations. C. Meets criteria for hospice referral. D. Demonstrates intact IADL function. Got a guess? Lock it in. The correct answer is B. Has selective IADL limitations. B is correct because instrumental activities of daily living include shopping, finances, transportation, food preparation, and medication management. This client manages some tasks but has lost finances and driving, making the deficit selective rather than global, with community supports able to fill gaps. Is wrong because nursing home placement is considered when basic activities of daily living are lost or safety at home cannot be assured. Selective gaps can typically be filled by family help or community programs. C is wrong because hospice is reserved for clients with a terminal prognosis of 6 months or less. Losing 2 instrumental activities does not indicate end-of-life status and would not qualify the client for hospice services. D is wrong because intact function means independent performance of every complex daily task. Loss of finances and driving represents measurable decline that the nurse should document and address with appropriate community resource referrals. When assessing a client's functional independence, clinicians rely on 2 distinct scales: activities of daily living and instrumental activities of daily living. Understanding the difference is essential for matching the right level of care to each client's actual deficits. ADLs are basic self-care tasks measured by the CAT scale. They include bathing, dressing, toileting, continence, transferring from bed to chair, and feeding oneself once food is prepared. A client who cannot perform several of these needs hands-on caregiver support. IADLs are more complex tasks measured by the Lawton scale. They require executive function and multi-step cognition. things like managing medications, handling finances, shopping, using transportation, and food preparation. These skills typically decline before basic self-care does. The dividing line between the two categories is usually whether a task requires community navigation, scheduling, or financial decision-making. Feeding oneself is a basic ADL, but preparing the food is an IADL. Transferring from bed to chair is basic, but navigating public transit is instrumental. Instrumental skills fade before basic self-care because the cognitive demand is higher. A client losing IADLs first may only need home modifications or community services, while a client losing ADLs often requires assisted living or skilled nursing. Always match the level of care to where the actual deficits are. Question 17. A client newly diagnosed with amyotrophic lateral sclerosis lives at home with a spouse and is beginning to have difficulty swallowing solid foods. The clinic nurse is planning teaching for the family about meal safety. Which intervention by the nurse is most appropriate for this client? Your options are: A. Encourage thin liquids and rapid eating. B. Reposition the client's supine to swallow. C. Provide soft foods and thickened liquids. D. Allow the client to feed alone. Which one is it? Pause the video if you need more time. The correct answer is C. Provide soft foods and thickened liquids. C is correct because soft foods with thickened liquids reduce aspiration risk, as swallowing muscles weaken with disease progression. Sitting fully upright during meals and for 30 minutes afterward uses gravity to keep food moving safely down the esophagus, rather than into the airway. A is wrong because thin liquids are the consistency most likely to be aspirated when swallowing coordination begins to fail. Rushing meals further increases the chance of food entering the airway before protective reflexes have time to engage. B is wrong because lying supine eliminates gravity assistance and dramatically raises aspiration risk during eating. Standard practice positions the client at 90 degrees throughout the meal and for at least 30 minutes after eating. D is wrong because unsupervised meals in clients with progressive bulbar weakness can lead to silent aspiration that goes unnoticed. A caregiver should remain present to monitor swallowing and respond immediately to any choking event. Amyotrophic lateral sclerosis gradually destroys the motor neurons that coordinate swallowing, putting patients at serious risk for aspiration. Understanding the mechanics behind this helps explain every safe swallowing recommendation. In a healthy swallow, the tongue pushes food back, the soft palate seals the nasopharynx, the epiglottis covers the airway, and the pharyngeal constrictors move the bolus into the esophagus. When ALS weakens these muscles, coordination slows and material can silently enter the trachea, often without any cough to signal it. Diet modifications center on two key changes: choosing soft moist foods like scrambled eggs or mashed vegetables, and thickening all liquids. Thin liquids move too fast for a slowed swallow reflex, making thickened liquids paradoxically safer than water or juice. Positioning is the second pillar of safety. The patient sits fully upright at 90 degrees and stays upright for at least 30 minutes after eating. A chin tuck on each swallow narrows the laryngeal opening, and bites are kept to no more than half a teaspoon to reduce the risk of airway spillage. Together, texture modification and careful positioning buy critical time while oral intake is still possible. When swallowing becomes unsafe despite these measures, enteral nutrition through a gastrostomy tube becomes the next step. Question 18. The nurse is preparing to transport a client with active pulmonary tuberculosis from radiology back to the medical unit. The route passes through public hallways and an elevator. Which action by the nurse is most appropriate during transport? Your options are: A. Place an N95 respirator on client. B. Keep the client's room door open. C. Use only quiet corridors for transport. D. Place a surgical mask on the client. Take a second. Which answer would you pick? The correct answer is D. Place a surgical mask on the client. D is correct because during transport under airborne precautions, the client wears a surgical mask as source control, while staff continue wearing fit-tested N95 respirators. The receiving department is notified in advance so the client can be moved directly into a designated isolation area. A is wrong because the N95 is engineered to protect the wearer from inhaling airborne particles, not for source control on an ill client. Surgical masks are designed to contain the client's respiratory droplets at the source. B is wrong because the airborne infection isolation room door must remain closed at all times to preserve negative pressure. Leaving it open releases contaminated air into the corridor and defeats the engineered ventilation of the room. C is wrong because route selection alone does not contain airborne droplet nuclei, which travel long distances on air currents. A surgical mask on the client plus N95s on staff are the actual barriers required during transport. Airborne precautions apply to diseases spread by tiny droplet nuclei that stay suspended in the air and travel far beyond the source. The classic examples are pulmonary tuberculosis, measles, varicella, and disseminated zoster. Inside the hospital, the engineering control is an airborne infection isolation room, formerly called a negative pressure room. Directional airflow pulls air into the room, and it exhausts through HEPA filtration so infectious particles never escape into the hallway. Once the client leaves the negative pressure room, the protection strategy shifts. The client wears a surgical mask for source control, catching droplets at the point of origin. Staff continue wearing fit-tested N95 respirators because they are inhaling air that may carry infectious nuclei. Transport follows a methodical protocol. The receiving department is notified first so hallways and elevators can be cleared. The client is masked before the door opens. Transporters keep their N95s on the entire trip, and the isolation room doors stay closed to preserve the pressure differential. Airborne precautions are the most stringent tier. Droplet precautions, used for influenza and pertussis, require only a surgical mask for staff within 3 to 6 feet. The key distinction on exam day is that airborne requires N95 respirators for staff, not standard surgical masks, while the client is always masked at the source during transport regardless of precaution level. Question 19. A client recovering from a recent myocardial infarction reports sharp chest pain that worsens with deep inspiration and improves when leaning forward. The nurse auscultates a scratchy 3-component sound at the left lower sternal border. Which condition does the nurse suspect? Your options are A. Recurrent myocardial ischemia, B. Cardiogenic pulmonary edema, C. Acute pericarditis, D. Extension of an aortic dissection. Before I reveal it, which one do you think is right? The correct answer is C. Acute pericarditis. C is correct because pleuritic chest pain relieved by leaning forward, paired with a pericardial friction rub, are hallmark features of pericarditis. Post-infarction inflammation, known as Dressler syndrome, often produces this presentation within days to weeks after the original event. A is wrong because recurrent ischemic pain follows a pressure or squeezing pattern, lacks positional relief, and is not accompanied by a friction rub. Ischemic pain also responds to nitroglycerin, while pericardial inflammation does not. B is wrong because cardiogenic pulmonary edema produces severe dyspnea, pink frothy sputum, and diffuse crackles. The presentation here lacks fluid overload signs and instead centers on positional pleuritic chest pain typical of pericardial inflammation. D is wrong because aortic dissection produces sudden tearing pain radiating to the back, often with unequal arm pressures. A friction rub and reproducible relief on leaning forward point clearly away from a dissecting aorta. After a myocardial infarction, inflammation can spread from the necrotic muscle to the surrounding pericardial sac. This is post-infarction pericarditis. Understanding the anatomy of the pericardium explains every clinical feature you will encounter at the bedside. The pericardium has two layers. The visceral layer sits directly on the myocardium, and the parietal layer forms the outer boundary. A thin film of lubricating fluid between them allows the heart to glide smoothly. When these layers become inflamed, that smooth glide is replaced by friction. The pain of pericarditis is sharp or stabbing, never the dull pressure of ischemia. It worsens when the patient lies flat, because the heart presses against the inflamed parietal pericardium, and it improves when the patient leans forward, moving the heart away from that surface. Deep inspiration also aggravates pain because pleural movement increases friction. Post-infarction pericarditis takes two forms. The early form appears within 1 to 3 days as inflammation from the necrotic myocardium extends to the overlying pericardium. Dressler syndrome is the late form, appearing weeks to months later, driven by an autoimmune response to released myocardial antigens. At the bedside, a pericardial friction rub, a scratchy, leathery sound best heard with the patient leaning forward, often confirms the diagnosis. The ECG shows diffuse ST elevation across multiple leads with PR depression, distinguishing pericarditis from the focal ST changes of acute ischemia. These findings together make the diagnosis. Question 20. The nurse performs a focused respiratory assessment on a client with an acute exacerbation of chronic obstructive pulmonary disease. The nurse notes pursed lip breathing, accessory muscle use, and expiratory wheezing throughout the chest. Which additional finding requires immediate follow-up? Your options are A. Pursed lip breathing during exhalation. B. Accessory muscle use with exertion. C. Bilateral expiratory wheezing. D. Sudden inspiratory stridor. What's your answer? Commit to one before I continue. The correct answer is D. Sudden inspiratory stridor. D is correct because among these findings, only stridor signals upper airway obstruction, a true emergency requiring immediate airway evaluation and possible intubation. Stridor demands rapid intervention regardless of the underlying disease and takes precedence over expected exacerbation findings such as wheezing. A is wrong because pursed lip breathing is an adaptive technique that prolongs expiration and reduces air trapping. Encouraging the technique aligns with established chronic obstructive pulmonary disease education and does not warrant urgent reversal by the nurse. B is wrong because accessory muscle use reflects increased work of breathing but is expected during exacerbations. Treatment with bronchodilators and corticosteroids addresses the obstruction rather than calling for immediate airway rescue in this client. C is wrong because expiratory wheezing in this population reflects lower airway narrowing that responds to inhaled bronchodilators. While important, wheezing does not carry the imminent obstruction risk that stridor presents at the upper airway. Stridor is a high-pitched, harsh inspiratory sound caused by turbulent airflow through a critically narrowed upper airway. Unlike the familiar wheeze of asthma or COPD, stridor is never a routine finding. It signals an airway emergency requiring immediate action. It helps to distinguish stridor from other adventitious sounds. Wheeze is expiratory and polyphonic, arising from narrowed intrathoracic airways. Crackles and raunchy signal lower airway or alveolar pathology. Only stridor points to the larynx, glottis, or upper trachea, the single conduit where small additional narrowing causes dramatic resistance increases. The anatomy explains the danger. The airway narrows naturally at the larynx where the vocal cords sit. because airflow resistance rises with the fourth power of any radius reduction. Even a small amount of additional edema or obstruction at this level can take a patient from audible stridor to complete obstruction within minutes. The causes of new stridor in adults are specific and limited: anaphylaxis with laryngeal edema, epiglottitis, inhalation injury, post-extubation swelling, foreign body, and tumor. None of these are watchful waiting diagnoses. Each one demands immediate airway evaluation. On exam day, the moment you read stridor, high-pitched inspiratory sound, or upper airway in a question, recognize it as the most urgent finding in any list. Call for help, maximize oxygen, summon the most experienced airway clinician, and prepare for advanced airway management without delay. Question 21. The nurse is planning pressure injury prevention for a bedbound client with a Braden score of 14. The client uses incontinence briefs and the head of the bed sits at 30 degrees during meals. Which intervention by the nurse is most appropriate? Your options are: A. Reposition every 2 hours, offload heels. B. Place a donut cushion under sacrum. C. Massage reddened areas for circulation. D. Keep head of bed at 90 degrees. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Reposition every 2 hours, offload heels. A is correct because repositioning every 2 hours and offloading the heels with pillows under the calves is the most evidence-based prevention strategy. These actions redistribute pressure away from bony prominences and protect the heels, where injuries are common and difficult to heal. B is wrong because a donut cushion concentrates pressure around its rim, cutting off blood flow in a ring around the targeted area. Current evidence-based guidelines avoid these cushions because they create new pressure injuries rather than preventing them. C is wrong because massaging reddened tissue damages already compromised capillary beds. Friction and shear forces from massage worsen tissue injury and are explicitly contraindicated in current evidence-based pressure injury prevention recommendations. D is wrong because keeping the head of bed at 90 degrees increases shear forces as the client slides down the mattress. The recommended position is below 30 degrees whenever the clinical condition allows safe lowering. Pressure injuries develop when sustained pressure over a bony prominence exceeds capillary perfusion pressure long enough to cause tissue ischemia. Understanding why they form helps explain every prevention strategy we use. The most vulnerable sites in a bedbound patient are the sacrum, heels, ischial tuberosities, trochontas, and occiput, wherever bone sits close to the skin surface with minimal soft tissue padding between. The Braden scale is the validated risk assessment tool. It scores 6 categories: sensory perception, moisture, activity, mobility, nutrition, and friction and shear, with a total score of 18 or below triggering a full prevention bundle. The 3 pillars of prevention are repositioning every 2 hours, heel offloading with pillows under the calves, and keeping the head of the bed at 30 degrees or less to reduce shear across the sacrum. Repositioning is the single most evidence-based strategy. On exam day, when you see bedbound, Braden score, or sacrum, the answer is repositioning every 2 hours with heel offloading. Massaging reddened areas is contraindicated because it extends microvascular damage rather than relieving it. Question 22. A community health nurse is planning diabetes education for a Hispanic neighborhood with limited English proficiency. The nurse has bilingual brochures and access to local community organizations. Which strategy by the nurse best demonstrates evidence-based community health practice for this population? Your options are: A. Weekend hospital lectures in English. B. Mailings with phone-based translation lines. C. English brochures to encourage learning. D. Local partnership with trained promotores. Which would you go with? Lock it in before the reveal. The correct answer is D. Local partnership with trained promotores. D is correct because promotores are trusted community health workers who share language and cultural background with the population they serve. Engaging them at accessible local sites consistently outperforms hospital-based, English-only programs in producing measurable behavior change for Hispanic communities. A is wrong because hospital-based, English-only programming creates location, language, and cultural barriers all at once. Many community members will not attend, leaving the program unable to demonstrate population-level outcomes despite the nurse's investment. B is wrong because mailings in a non-preferred language with phone translation are passive and rarely change behavior. Effective community health design embeds learning in trusted relationships rather than unfamiliar print and telephone follow-up. C is wrong because forcing English exposure without language support actively disadvantages the clients being served. It also reflects an outdated assimilation mindset rather than the cultural humility now standard in community health nursing. Community health nursing moves care into the spaces where people actually live, neighborhoods, churches, and community centers. The goal isn't just language access, but genuine partnership built on trust, cultural fluency, and physical presence in the community. The field has moved from cultural competence, the idea that a nurse can master a list of traits, to cultural humility, which recognizes that culture is dynamic and best understood through the client's own words. The nurse enters a new community with curiosity, builds relationships first, and adapts the message rather than insisting on a single delivery model. Promotora de salud are community members not licensed clinicians, who share language, culture, and lived experience with the people they serve. They act as cultural brokers, connecting neighbors to formal healthcare through trust that no clinic appointment can manufacture. Research shows that promotora-led programs improve glycemic control, blood pressure outcomes, and screening uptake compared to standard clinic outreach. The mechanism comes down to 4 factors: trust and relationship, language match, cultural fluency, and physical accessibility, meeting people where they are, even on a neighbor's porch in the evening. Remember, translated materials close the language gap but don't address the broader social barriers to engagement. A program with perfect translation but no community partnership often fails. Promotores, accessible local sites, and community co-ownership are what actually move the needle. Question 23. A client being monitored on the telemetry unit suddenly becomes unresponsive. The monitor shows a chaotic, irregular waveform with no identifiable QRS complexes. The nurse rapidly confirms no palpable pulse and no spontaneous respirations. Which intervention should the nurse implement first? Your options are A. Defibrillate using 200 joules biphasic. B. Administer adenosine 6 mg rapid push. C. Perform synchronized cardioversion at 50 joules. D. Begin amiodarone infusion before any shock. Don't overthink it. Which one feels right? The correct answer is A. Defibrillate using 200 joules biphasic. A is correct because the chaotic pulseless rhythm describes ventricular fibrillation, and unsynchronized defibrillation is the only intervention that can restore organized electrical activity. Early defibrillation paired with high-quality chest compressions offers the best chance of return of spontaneous circulation. B is wrong because adenosine targets supraventricular tachycardia by blocking conduction through the atrioventricular node in conscious clients. A pulseless ventricular dysrhythmia requires electrical defibrillation rather than pharmacologic conversion of a supraventricular focus. C is wrong because synchronized cardioversion requires an identifiable R wave to time the shock. A chaotic pulseless rhythm offers no organized R wave for synchronization, so attempting cardioversion would only delay the life-saving unsynchronized shock. D is wrong because antiarrhythmic agents follow the first or second shock during arrest, never replacing defibrillation. Drug delivery without restoring rhythm wastes critical minutes while the brain is being starved of perfusion and oxygen. Ventricular fibrillation is a life-threatening arrhythmia where chaotic electrical activity in the ventricles produces no coordinated contraction and no cardiac output. Understanding why it happens and how to stop it is essential for any clinical exam. On the monitor, ventricular fibrillation appears as a chaotic, irregular waveform with no identifiable P waves, QRS complexes, or T waves. The ventricles quiver rather than pump, and within seconds the patient loses pulse, blood pressure, and consciousness. The pathophysiology involves multiple wandering re-entrant electrical circuits. DUTs, often triggered by ischemia, that compete across the ventricular myocardium all at once. None of them organizes a coordinated depolarization, so the mechanical pump fails completely. No inotropic support or compressions alone will restore function until the chaotic electrical activity is interrupted. Defibrillation works by delivering a high-energy shock that simultaneously depolarizes a critical mass of myocardium, terminating the re-entrant circuits and allowing the heart's intrinsic pacemaker to resume control. The shock is unsynchronized because there is no organized R wave to trigger it. On exam, distinguish ventricular fibrillation from similar rhythms. Pulseless ventricular tachycardia is wide and regular, but still treated with defibrillation. Pulseless electrical activity shows organized electrical activity with no pulse, and asystole is flatline. Neither is treated with defibrillation. Synchronized cardioversion is reserved for unstable, organized rhythms with a discernible R wave. Question 24. Before drawing morning labs that include blood cultures, a complete blood count, and coagulation studies, the phlebotomy nurse organizes the supplies at the bedside. Which order of draw should the nurse follow to prevent contamination and additive carryover between tubes during the collection? Your options are A. Light blue, blood cultures, lavender. B. Blood cultures, light blue, lavender. C. Lavender, blood cultures, light blue. D. Blood cultures, lavender, light blue. Got a guess? Lock it in. The correct answer is B. Blood cultures, light blue, lavender. B is correct because the standard order of draw begins with blood cultures to maintain sterility, then light blue tubes for coagulation studies, followed by lavender for the complete blood count. The sequence preserves accurate results by preventing additive carryover between consecutive tubes. A is wrong because drawing the light blue tube before blood cultures risks contaminating the culture and the coagulation specimen. The culture must come first to preserve sterility, after which additive tubes follow in the established sequence. C is wrong because the lavender tube belongs after the coagulation tube, not before the cultures. Reversing this order permits ethylene-diamine cetracetic acid carryover that distorts coagulation results and compromises sterility of the cultures. D is wrong because the lavender tube must follow the light blue tube. Placing lavender ahead of coagulation studies risks ethylene-diamine triacetic acid contamination that falsely prolongs clotting times and erodes confidence in the coagulation panel. The order of draw is a standardized sequence for filling blood collection tubes during a single venipuncture. It exists for one core reason: to prevent additive carryover from one tube from contaminating the next and falsifying lab results. Modern assays are sensitive enough that tiny amounts of carryover matter. ETA from a lavender tube chelates calcium, throwing off coagulation results. An underfilled citrate tube skews the sodium citrate ratio, and a culture bottle drawn after other tubes risks introducing false contaminants. The CLSI published sequence runs blood cultures first to preserve sterility, then the light blue citrate tube for coagulation studies, then serum tubes, then the lavender editor tube for the complete blood count, and finally grey fluoride tubes for glucose. Visualizing the tubes in sequence helps cement the order. Cultures sit at the top to protect sterility. The light blue tube follows because citrate coagulation studies are highly sensitive to contamination. Serum, ETA, and fluoride tubes complete the draw in that order. Remember the sequence: cultures, citrate, serum, ETA, fluoride, and you prevent the specific, well-documented contamination errors that can lead to wrong diagnoses and incorrect treatment. Question 20. A postpartum mother newly diagnosed with a methicillin-resistant Staphylococcus aureus wound infection is being discharged home. She lives with the infant, a healthy adult sister, and a school-age niece in the same household. Which discharge instruction by the nurse is most appropriate? Your options are: A. Wash hands around wound contact. B. Apply contact isolation for 2 weeks. C. Family members must wear gowns. D. Niece should sleep at another home. Which one is it? Pause the video if you need more time. The correct answer is A. Wash hands around wound contact. A is correct because home management of methicillin-resistant Staphylococcus aureus relies on hand hygiene before and after wound contact, keeping the wound covered with a clean dressing, and avoiding shared personal items like towels. Full contact isolation is not required at home. B is wrong because hospital-style contact isolation is unnecessary at home for routine household contacts. Home transmission risk is managed through hand hygiene, dressing integrity, and laundry practices rather than full gown and glove protocols around the kitchen. C is wrong because gowns add no protection in a non-clinical environment with healthy household members. Recommended home measures emphasize hand hygiene and not sharing personal items, not donning healthcare personal protective equipment. D is wrong because separating the niece is not part of standard home management of methicillin-resistant Staphylococcus aureus. School-age children with intact skin and good hand hygiene face minimal transmission risk in the household. Methicillin-resistant Staphylococcus aureus spreads at home through direct contact with wounds, wound drainage, or contaminated surfaces, not through the air. Understanding this transmission route shapes every home management instruction we give at discharge. Wondrous A skin and wound infections shed organism onto hands and surfaces. From there, the organism reaches household contacts through touch. Because aerosol spread is not part of wound infection biology, masks and respiratory precautions are not needed at home. 3 practices interrupt home transmission: thorough hand hygiene before and after wound contact, keeping the wound covered with a clean, dry dressing at all times, and not sharing personal items such as towels, washcloths, or razors that touch the skin. Hand hygiene is the single most important step. Soap and water for at least 20 seconds removes organisms that would otherwise contaminate surfaces. Used dressings go into a sealed bag. No special biohazard disposal is required for routine home wound care. Hospital-level isolation, gowns, gloves, relocating the infant is not needed at home. The exam tests whether you recognize that simple contact precautions protects the household, and that hand hygiene before and after wound care is always the cornerstone answer. Question 26. The nurse is collecting blood cultures from a febrile client suspected of having endocarditis. The prescriber has ordered 2 sets from 2 different sites with no delay in antibiotic initiation. Which approach by the nurse best supports accurate culture results in this situation? Your options are A. Give antibiotics first, then cultures. B. Draw cultures from one site only. C. Draw both sets before antibiotics begin. D. Draw cultures from a central line only. Take a second. Which answer would you pick? The correct answer is C. Draw both sets before antibiotics begin. C is correct because 2 sets from 2 different peripheral sites improve sensitivity and help distinguish skin contamination from true bacteremia. Cultures must be obtained before antibiotics begin to preserve the chance of identifying the causative organism and tailoring therapy with sensitivities. A is wrong because giving antibiotics before cultures sharply reduces culture yield and obscures the causative organism. Bundled care requires drawing cultures first whenever clinically feasible to keep diagnostic accuracy intact for later antibiotic narrowing. B is wrong because a single site cannot reliably separate skin contamination from true infection. 2 sets from 2 sites improve sensitivity and help interpret growth patterns when the microbiology results return to the unit. D is wrong because drawing only from a central line increases the risk of capturing line colonization rather than true bloodstream infection. Peripheral draws are preferred, with central line samples used only in paired comparison. Blood cultures are the cornerstone diagnostic test for suspected bloodstream infections. Understanding how they work and how they're collected explains why the standard protocol exists and what happens when it's not followed correctly. The standard for adults is 2 sets drawn from 2 different peripheral sites. Each set contains an aerobic and an anaerobic bottle. Drawing from 2 sites serves 2 purposes. It improves sensitivity for intermittent bacteremia, and it separates true pathogens, which grow in both sets, from skin contaminants, which typically appear in only one. At each site, the skin is prepped with chlorhexidine in alcohol and allowed to dry fully before puncture. The bottle tops are wiped with alcohol before inoculation. Collection volume, HESI Exit, typically 8 to 10 milliliters per bottle in adults, matters because underfilled bottles have meaningfully lower sensitivity. Cultures must be drawn before the first dose of empiric antibiotics whenever possible, because antibiotics in the bloodstream can reduce organism growth in culture media dramatically, sometimes by an order of magnitude. The guiding principle: draw cultures first, but never delay antibiotics waiting for cultures in a patient with septic shock. On exam day, the signal language to watch for includes suspected sepsis, fibrillation, before antibiotics, and 2 sets from 2 sites. Single bottle draws you miss both the sensitivity benefit and the contamination check. 2 complete sets from 2 peripheral sites remains the standard. Question 27. A client on home peritoneal dialysis calls the clinic to report that the drained dialysate effluent appears cloudy this morning. The client also describes new mild abdominal pain since the morning exchange. Which response by the nurse is most appropriate? Your options are A. Continue exchanges, call back tomorrow. B. Drink extra water to dilute dialysate. C. Skip the next exchange and rest. D. Come to clinic with cloudy drainage. Before I reveal it, which one do you think is right? The correct answer is D. Come to clinic with cloudy drainage. D is correct because cloudy effluent during peritoneal dialysis strongly signals peritonitis and requires prompt evaluation with culture and intraperitoneal antibiotics. Bringing the drainage bag to the clinic shortens the diagnostic process and allows targeted treatment to begin before infection spreads further. A is wrong because delaying evaluation of suspected peritonitis allows infection to spread and damage the peritoneum. Waiting until tomorrow could lead to sepsis or permanent loss of the dialysis modality for the stable home client. B is wrong because oral hydration does not address an intra-abdominal infection in any meaningful way. Fluid intake alone changes nothing about the inflammatory response within the peritoneal cavity that is causing the cloudy effluent today. C is wrong because skipping exchanges does not treat infection and may allow uremia to develop quickly. The cloudy appearance demands diagnostic workup rather than home self-management strategies that ignore the underlying infectious process. Peritoneal dialysis uses the peritoneum as a natural filter, but the same access creates a serious infection risk. When bacteria enter the peritoneal cavity, the result is peritonitis, the most common complication that drives patients from home dialysis to hemodialysis. Dialysate fluid enters through a catheter, dwells in the abdomen, and drains out. Solutes like urea and creatinine move down concentration gradients into the fluid, while excess water moves by osmosis driven by glucose in the dialysate. The hallmark finding is cloudy effluent. The drained bag turns turbid as white blood cells flood the peritoneal cavity. Diagnosis is confirmed when the dialysate cell count exceeds 100 white cells per microliter, with a polymorphonuclear predominance on gram stain and culture. 3 diagnoses overlap clinically. An exit site infection stays at the skin and responds to topical or oral antibiotics. A tunnel infection tracks along the catheter tract and is more serious. Peritonitis, signaled by cloudy effluent and abdominal pain, requires intraperitoneal antibiotics delivered directly into the cavity where the bacteria are growing. On exam, cloudy effluent combined with abdominal pain names peritonitis. The immediate actions are to culture the dialysate and start empiric intraperitoneal antibiotics covering both gram-positive and gram-negative organisms. The catheter is preserved unless the infection fails to clear. Question 28. The nurse performs orthostatic vital signs on an older client who reports dizziness today. Supine pressure is 132/78 with heart rate 70. After 3 minutes standing, the pressure is 108/64 and heart rate 92. Which interpretation by the nurse is correct? Your options are A. Positive orthostatic hypertension, B. Normal hemodynamic adjustment, C. Hypertensive emergency needing therapy, D. Reflex bradycardia from a vagal event. What's your answer? Commit to one before I continue. The correct answer is A. Positive orthostatic hypertension. A is correct because orthostatic hypertension is defined as a systolic drop of at least 20 millimeters of mercury, a diastolic drop of at least 10, or a heart rate rise of 20 beats within 3 minutes of standing. This client meets criteria. B is wrong because a 24-point systolic drop coupled with a 22-beat heart rate increase exceeds normal compensatory limits. Healthy postural adjustment maintains stable cerebral perfusion, while this client's response signals impaired vasoconstriction or volume depletion. C is wrong because hypertensive emergencies feature systolic pressures above 180 with evidence of target organ damage. The falling pressure on standing here rules out emergency hypertension and would make antihypertensives harmful. D is wrong because the heart rate rose rather than fell, ruling out a vasovagal episode. Reflex bradycardia is accompanied by bradycardia, pallor, and sweating, whereas this client demonstrates compensatory tachycardia in response to falling pressure. Orthostatic hypotension occurs when blood pressure drops significantly upon standing because the body's normal compensatory reflexes fail to keep up. Understanding the mechanism, measurement protocol. and diagnostic criteria helps clinicians identify and act on this condition quickly. Normally, standing triggers a sympathetic reflex with three key responses: venous vasoconstriction, arterial vasoconstriction, and a slight heart rate rise. Together, these maintain cerebral perfusion despite gravity pulling blood toward the legs. When this reflex fails, cerebral perfusion pressure drops and the person becomes dizzy or faints. The measurement protocol is straightforward. The client lies supine for at least 5 minutes while baseline blood pressure and heart rate are recorded. Values are then recorded after 1 minute of standing, and optionally again at 3 minutes to catch delayed forms. A positive test requires at least one of these findings within 3 minutes of standing: a systolic drop of 20 or more millimeters of mercury, a diastolic drop of 10 or more, or a heart rate rise of 20 or more beats per minute. Notably, a brisk heart rate rise suggests volume depletion, while the absence of any rise points to autonomic failure. Remember that postural orthostatic tachycardia syndrome shows a large heart rate rise without a significant pressure drop, while vasovagal syncope involves bradycardia triggered by emotional stress. Classic orthostatic hypotension is defined by a clear pressure drop with a predictable heart rate pattern within 3 minutes of standing. Question 29. The nurse is monitoring a laboring client at 38 weeks gestation who is receiving oxytocin augmentation. The continuous fetal heart rate strip shows late decelerations during 3 consecutive contractions with minimal baseline variability. Which intervention should the nurse implement first for this client? Your options are A. Document and continue routine monitoring. B. Reposition left side, stop oxytocin. C. Increase oxytocin to speed delivery. D. Apply a fetal scalp electrode. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Reposition left side, stop oxytocin. B is correct because late decelerations signal uteroplacental insufficiency. Lateral positioning improves placental perfusion. Stopping oxytocin reduces uterine stress. And supplemental oxygen with an intravenous fluid bolus and prescriber notification complete the standard intrauterine resuscitation bundle for this pattern. A is wrong because passive monitoring during late decelerations allows fetal hypoxia and acidemia to worsen. This category 2 or 3 pattern demands active intrauterine resuscitation rather than continued observation while the strip deteriorates further. C is wrong because increasing oxytocin intensifies the uterine stress that is causing the late decelerations. More contractions further compromise placental perfusion and accelerate fetal compromise rather than relieving it for the laboring client. D is wrong because a fetal scalp electrode improves signal quality but does not treat the hypoxic cause. Better tracing does not help a fetus whose placenta is failing. Restoring perfusion is the priority intervention now. To understand late decelerations, we need to look at what the fetal heart rate strip is actually telling us about oxygen delivery to the fetus. The key is the relationship between heart rate changes and the timing of contractions. On the strip, a late deceleration is gradual in onset, reaches its lowest point, the nadir, after the peak of the contraction, and recovers gradually after the contraction ends. This consistent time lag is what distinguishes it from other patterns. The mechanism is uteroplacental insufficiency. Every contraction compresses the spiral arteries supplying the placenta. A healthy placenta has enough reserve to handle this, but an insufficient placenta from hypertension, oxytocin overstimulation, abruption, or chronic disease cannot, and each contraction unmasks fetal hypoxia. Distinguishing the 3 patterns is critical. Early decelerations mirror contractions and reflect head compression. They are benign. Variable decelerations are abrupt and V-shaped, caused by cord compression. Late decelerations are gradual and consistently lag behind contractions, signaling uteroplacental insufficiency. The bedside response targets the cause. Place the mother in the left lateral position to improve placental perfusion. Stop the oxytocin immediately to reduce uterine compression. Then give an IV fluid bolus and supplemental oxygen by face mask while notifying the obstetric team. Question 30. The nurse is preparing to administer scheduled morning medications to a post-operative client on a busy surgical unit. The wristband, electronic record, and bedside scanner are all available at the point of care. Which action by the nurse meets the national patient safety goal for 2 client identifiers? Your options are A. Have client's date, name, and birth date. B. Match the room number 2 chart. C. Confirm yes or no whether identity correct. D. Verify diagnosis matches the order. Which would you go with? Lock it in before the reveal. The correct answer is A. Have client's date, name, and birth date. A is correct because 2 acceptable identifiers, requested open-endedly and compared with the wristband, meet the national patient safety goal. Asking the client to state name and date of birth avoids yes or no confirmation errors and aligns with the Joint Commission standard for medication administration. B is wrong because room and bed numbers are explicitly excluded from acceptable client identifiers. Clients are moved between rooms during a stay, and a chart at the wrong bedside could lead to giving medication to the wrong person. C is wrong because yes or no questions invite a confused or hard of hearing client to nod incorrectly. The standard requires the client to state identifying information rather than simply confirm an assumption voiced by the nurse. D is wrong because diagnosis is not a client identifier and may be shared across many clients on the unit. Verifying disease does nothing to confirm the identity of the specific person about to receive medication. Patient identification before any medication, procedure, or sample collection is a national patient safety goal set by the Joint Commission. Wrong patient errors are a documented source of serious harm, and a 2 identifier check at every intervention is the standard that prevents them. The 2 identifiers must each be truly patient-specific. Acceptable examples include full name and date of birth, a medical record number, or a unique encounter number. Room number and diagnosis are never acceptable. Room assignments change and diagnoses are not unique to one individual. Verification method matters as much as the identifiers themselves. The nurse asks the client to state name and date of birth rather than asking a yes or no question. This open-ended approach forces the client to produce the data, eliminating the risk that a confused, sedated, or polite patient confirms an incorrect prompt. The wristband is the physical reference point. It is applied at admission and replaced if it becomes illegible or removed. Many institutions add barcode scanning at medication administration. Comparing the wristband barcode with the medication and the electronic order, barcoding adds a layer. It does not replace verbal verification. The consistent exam answers 2 patient-specific identifiers, requested open-endedly, and compared with the wristband and the order at the same moment. Room number, diagnosis, and yes or no confirmation all fall below the standard, and skipping any step removes redundancy the system depends on. Question 31. The nurse caring for a post-operative client discovers the abdominal wound has dehisced, with loops of bowel visible at the surface. The client is alert and reports sudden pain in the area. Which action should the nurse take first while awaiting the surgical team? Your options are A. Push the tissue back into abdomen. B. Encourage the client to ambulate slowly. C. Remove dressings, apply dry sterile pads. D. Cover with saline gauze, low Fowlers. Don't overthink it. Which one feels right? The correct answer is D. Cover with saline gauze, low Fowler's. D is correct because evisceration requires immediate covering of exposed bowel with sterile saline-soaked gauze to keep the tissue moist. Low Fowler's position with knees flexed reduces abdominal tension while the nurse contacts the surgeon, keeps the client NPO, and monitors for shock. I was wrong because attempting to push exposed bowel back into the abdomen risks tissue injury, contamination, and severe pain. Reintroduction of viscera requires sterile surgical conditions, not a bedside maneuver during the initial emergency response. B is wrong because ambulation increases abdominal pressure and the chance of further tissue extrusion. The client must remain still in low Fowler's with knees flexed to minimize strain on the dehisced incision and protect exposed viscera. C is wrong because dry gauze allows exposed bowel to desiccate quickly, causing additional tissue injury. Saline moistened sterile dressings are the standard until surgical reduction and definitive closure occur in the operating room. When a postoperative abdominal wound opens and intestinal loops become visible at the surface, the condition is called evisceration, and it demands an immediate, precise nursing response before the surgical team arrives. Dehiscence is separation of the wound layers, while evisceration is the more severe form where bowel actually protrudes. Both tend to occur in the first 1 to 2 weeks after surgery, when collagen deposition hasn't yet given the wound enough tensile strength, and are often triggered by coughing, vomiting, or straining. The bowel protrudes through both the fascial and skin layers at the incision site. The immediate priority is to cover those exposed loops with sterile gauze moistened with sterile saline, which protects the serosal surface from drying out and tissue damage. Never attempt to push the bowel back, as that risks injury and peritoneal contamination. 3 actions happen in rapid sequence. Cover the exposed bowel with sterile saline-soaked gauze. Position the client in low Fowler's with knees flexed to reduce abdominal wall tension, and immediately notify the surgical team. IV access is confirmed. Vital signs are monitored continuously, and the client is kept NPO in preparation for return to the operating room. On exam day, whenever you see bowel visible at an abdominal wound, the answer sequence is always the same. Moist, sterile gauze first, low Fowler's position with knees flexed, then the surgical team. Dry gauze, pushing bowel back, or sitting fully upright are all wrong answers. Question 32. A client with newly diagnosed acute lymphoblastic leukemia receives the first dose of chemotherapy. Within hours, the potassium is 6.4. Phosphorus is 7.2. Uric acid is 12.8. And calcium is 7.0. Which complication does the nurse suspect? Your options are A. Hypercalcemia of underlying malignancy. B. Allergic reaction to chemotherapy drug. C. Tumor lysis syndrome developing. D. Acute kidney injury from contrast. Got a guess? Lock it in. The correct answer is C. Tumor lysis syndrome developing. C is correct because rapid cell death from chemotherapy releases intracellular contents that produce hyperkalemia, hyperphosphatemia, hyperuritemia, and secondary hypercalcemia, aggressive hydration, allopurinol or rasburicase, and electrolyte management form the backbone of prevention and treatment for tumor lysis syndrome. A is wrong because the serum calcium is low rather than high, the opposite of hypercalcemia of malignancy. The full electrolyte pattern here fits only one specific oncologic emergency that follows the initiation of cytotoxic chemotherapy. B is wrong because allergic chemotherapy reactions present with rash, bronchospasm, hypotension, or anaphylaxis rather than this electrolyte pattern. Immune-mediated reactions have no direct mechanistic link to the biochemical shifts shown on these labs. D is wrong because contrast nephropathy raises creatinine and urea but does not produce the specific tetrad of electrolytes. The triggering event in this scenario is rapid cell lysis from chemotherapy rather than radiology contrast dye. Tumor lysis syndrome is a metabolic emergency triggered when massive numbers of cancer cells die rapidly, flooding the bloodstream with intracellular contents faster than the kidneys can clear them. It's most common with hematologic malignancies like acute lymphoblastic leukemia and Burkitt lymphoma, typically appearing within hours to days of the first effective chemotherapy dose. When cancer cells lyse, they release their intracellular contents in bulk. Potassium floods the serum, causing hyperkalemia. Phosphate rises and binds circulating calcium, driving hypocalcemia. Nucleic acids are broken down into uric acid, which can precipitate in renal tubules and cause acute kidney injury. The laboratory signature of tumor lysis syndrome is this 4-electrolyte pattern: hyperkalemia, hyperphosphatemia, hypercalcemia, and hyperuricemia. The Cairo-Bishop criteria formalize these thresholds and add clinical features like rising creatinine, cardiac arrhythmia, and seizure. Treatment centers on 3 pillars: aggressive intravenous hydration to push urine output above 100 milliliters per hour, uric acid management with allopurinol to block synthesis or rasburicase to enzymatically degrade existing urate, and serial laboratory monitoring throughout the first days of chemotherapy. Remember, tumor lysis syndrome has low calcium driven by phosphate binding, the opposite of hypercalcemia of malignancy. When you see the 4-electrolyte pattern alongside new chemotherapy and large tumor burden, start aggressive hydration and uric acid management immediately. Question 33. The nurse is initiating the sepsis bundle for a client newly identified with septic shock in the emergency department. The provider has authorized standing orders for the protocol. Which sequence of intervention should the nurse implement to meet the hour 1 expectations? Your options are A. Antibiotics first, then cultures and fluids. B. Cultures, lactate, antibiotics, fluids, pressors. C. Pressors first, then antibiotics and dialysis. D. Fluids only, reassess at 6 hours. Which one is it? Pause the video if you need more time. The correct answer is B. Cultures, lactate, antibiotics, fluids, pressors. B is correct because the surviving sepsis hour 1 bundle includes measuring lactate, drawing blood cultures before antibiotics, administering broad-spectrum antibiotics, beginning 30 milliliters per kilogram of crystalloid for hypotension or elevated lactate, and starting vasopressors if hypotension persists during fluid resuscitation. A is wrong because giving antibiotics before drawing cultures lowers culture yield and may obscure the causative organism. Cultures must precede antimicrobial administration whenever possible to preserve diagnostic accuracy and guide later targeted therapy. C is wrong because vasopressors are reserved for hypotension that persists during or after adequate fluid resuscitation. Starting vasoactive infusions before volume repletion worsens end organ perfusion and obscures the response to initial crystalloid administration. D is wrong because waiting 6 hours abandons the critical first hour window when antibiotics and fluids change mortality outcomes. Treating fluids as the only intervention ignores the simultaneous diagnostic and therapeutic steps the bundle requires. Sepsis is a life-threatening organ dysfunction from a dysregulated response to infection. Septic shock is the critical subset. Persistent hypertension requiring vasopressors to keep mean arterial pressure at or above 65, plus a lactate above 2 despite adequate fluids. The Surviving Sepsis campaign, our 1 bundle has 5 core elements. Measure lactate, draw blood cultures from 2 sites, Give broad-spectrum antibiotics. Start 30 milliliters per kilogram crystalloid for hypotension or high lactate, and initiate vasopressors if MAP stays below 65. Every step is time-stamped because each one independently ties to mortality. Lactate rises when poorly perfused tissues switch to anaerobic metabolism, reflecting the mismatch between oxygen delivery and demand. A lactate above 4 signals severe disease, even without hypertension. Trending lactate downward after resuscitation is one of the few real-time markers that treatment is working. Blood cultures should be drawn before antibiotics whenever possible, because antibiotic circulation dramatically reduces culture yield. However, antibiotics must never be delayed waiting for cultures. Even a 1-hour delay raises mortality. Empiric regimens combine piperacillin tazobactam or a carbapenem with vancomycin to cover methicillin-resistant gram-positive organisms. On the exam, when you see septic shock, the answer is the complete Hour 1 bundle. Choices that omit antibiotics, defer cultures and delay treatment, or restrict fluids in a hypotensive client all fall short of the standard of care. Question 34. A client with type 1 diabetes is admitted to the emergency department with diabetic ketoacidosis. The blood glucose is 612, the pH is 7.18, and the potassium is 5.6. After fluid resuscitation begins, which order would the nurse anticipate next? Your options are A. Continuous regular intravenous insulin infusion. B. Subcutaneous long-acting insulin every 12 hours. C. Oral sodium polystyrene for hyperkalemia. D. Sodium bicarbonate bolus to correct pH. Take a second. Which answer would you pick? The correct answer is A. Continuous regular intravenous insulin infusion. A is correct because after fluid resuscitation begins, a regular insulin infusion lowers glucose and reverses ketosis in a controlled, titratable manner. Insulin also drives potassium intracellularly, so close electrolyte monitoring and potassium replacement become critical as the serum level falls during treatment. B is wrong because subcutaneous long-acting insulin has too slow an onset to address an acute metabolic crisis. The titrateal intravenous route provides immediate effect that subcutaneous depot insulin cannot match during a life-threatening emergency presentation. C is wrong because the serum potassium will fall on its own as insulin moves it into cells. Adding a binder risks dangerous hypokalemia and is not part of standard diabetic ketoacidosis protocols during this early treatment phase. D is wrong because bicarbonate is reserved for severe acidosis with a pH below 6.9 in most current guidelines. The pH here does not meet that threshold, and routine bicarbonate can worsen cerebral edema risk. Diabetic ketoacidosis, or DKA, is a life-threatening complication of diabetes driven by severe insulin deficiency. Without insulin, the body cannot use glucose for fuel, so it breaks down fat instead, flooding the blood with ketone bodies and triggering a dangerous metabolic acidosis. The lab picture has 3 defining features: glucose above 250, a pH below 7.3, and strongly positive ketones with an elevated anion gap. Potassium may look normal or high at first because acidosis shifts it out of cells, but total body stores are actually depleted. Treatment follows a strict order. Isotonic fluids come first to restore perfusion. Potassium replacement must begin before insulin is started, because insulin drives potassium into cells and can unmask a dangerous deficiency. Only then is the insulin infusion initiated. The insulin infusion is the centerpiece of DKA management. Regular insulin is given intravenously at a low continuous dose, titrated to lower glucose no faster than 50 to 100 milligrams per deciliter per hour. When glucose reaches 200, dextrose is added so the infusion can continue clearing ketones without causing hypoglycemia. The key confusable is hyperosmolar hyperglycemic syndrome. Both share hyperglycemia and dehydration, but HHS has minimal ketones and a near normal pH, and tends to occur in older type 2 patients. Correctly naming the syndrome is what drives the right protocol, especially regarding insulin dosing and electrolyte priorities. Question 35. The nurse is monitoring a postpartum client receiving intravenous magnesium sulfate for severe preeclampsia. Respirations are 8 per minute. Patellar deep tendon reflexes are absent, and urine output over the past hour is 20 milliliters. Which medication would the nurse anticipate giving? Your options are A. Naloxone administered intravenous push, B. Protamine sulfate administered intravenously, C. Calcium gluconate administered intravenously, D. Vitamin K administered intramuscularly. Before I reveal it, which one do you think is right? The correct answer is C. Calcium gluconate administered intravenously. C is correct because calcium gluconate is the antidote for magnesium sulfate toxicity. Respirations below 12, absent deep tendon reflexes, and reduced urine output indicate dangerous magnesium levels. The nurse stops the infusion, administers intravenous calcium gluconate, supports ventilation, and monitors cardiac rhythm continuously. A is wrong because naloxone reverses opioid effects, not magnesium toxicity. Although both produce respiratory depression, the underlying mechanisms differ, and naloxone has no effect on the neuromuscular blockade caused by elevated magnesium levels. B is wrong because protamine sulfate is the antidote for heparin overdose. The medication binds heparin but plays no role in correcting the cardiac, respiratory, or reflex changes caused by magnesium accumulating beyond the therapeutic range. D is wrong because vitamin K reverses warfarin toxicity by restoring hepatic clotting factor synthesis. Vitamin K does nothing to counter the neuromuscular and respiratory depression seen in magnesium toxicity for this preeclamptic client. Magnesium sulfate is the go-to medication for preventing and treating seizures in severe preeclampsia and eclampsia. It raises the seizure threshold by acting as a central nervous system depressant and smooth muscle relaxant, dampening neuromuscular excitability throughout the body. The infusion starts with a loading dose of 4 to 6 grams, followed by a maintenance rate of 1 to 3 grams per hour. The therapeutic serum range is 4 to 7 milliequivalents per liter. Toxicity begins the moment levels climb above that ceiling. Magnesium works by competing with calcium at neuromuscular junctions, reducing acetylcholine release. At safe levels, this causes mild sedation and reduced reflexes. But as levels rise, deep tendon reflexes disappear, respiratory depression develops, and at very high concentrations, cardiac arrest can occur. Nurses assess respiratory rate, deep tendon reflexes, urine output, and level of consciousness every 1 to 2 hours. A respiratory rate of 12 or above and intact deep tendon reflexes signal a safe range. Because magnesium is renally excreted, urine output below 30 milliliters per hour allows dangerous accumulation. Any one of these thresholds drifting out of range demands immediate reassessment. When toxicity is recognized, the nurse stops the infusion immediately, administers 1 gram of 10% calcium gluconate intravenously over 3 to 5 minutes, and notifies the prescriber. Calcium gluconate, kept at the bedside at all times, displaces magnesium at the neuromuscular junction and rapidly reverses respiratory depression and conduction abnormalities. Question 36. A client is being transferred from the intensive care unit to a step-down floor after stabilization following a myocardial infarction. The transferring nurse is determining the best handoff approach to ensure continuity of care between units. Which approach by the nurse is most appropriate? Your options are A. Direct nurse-to-nurse SBAR bedside report, B. Faxed written summary only. C. A verbal report at the nurse's station. D. Electronic chart review by receiver. What's your answer? Commit to one before I continue. The correct answer is A. Direct nurse-to-nurse SBAR bedside report. A is correct because a warm bedside SPAR handoff lets the receiving nurse visualize lines, drains, and the client while asking clarifying questions. This direct exchange is the gold standard for transfer and reduces sentinel events linked to communication failures during transitions. B is wrong because a fax delivers static information with no opportunity for clarifying questions, important details about lines, contingency plans, or pending labs are easily missed when the receiver cannot ask questions in real time. C is wrong because reporting at the nurse's station keeps the client out of the loop and prevents visual verification of equipment and condition. Bedside handoff is preferred precisely because it pairs verbal exchange with direct observation. D is wrong because chart review alone does not equal a handoff. Recent events, contingency plans, and family concerns rarely live cleanly in the electronic record, so a structured verbal exchange remains essential to safe transfer. A handoff transfers responsibility for a patient from one nurse to another solely at shift change, unit transfer, or any care boundary. These moments carry the highest risk of information loss in inpatient care, which is why the Joint Commission has made handoff communication a national patient safety goal. Bedside warm handoff means the transferring and receiving nurses stand together at the bedside while report is given. Unlike a one-directional phone handoff, the receiving nurse can see lines, drains, and dressings in real time, ask clarifying questions on the spot, and the client can correct any misstatements. The key innovation is location. All three parties, transferring nurse, receiving nurse, and client, are at the same bedside simultaneously, so the verbal report, the visual inspection, and the client's own voice all happen at the boundary where information losses would otherwise concentrate. The content of the report follows SPAR. Situation names the client and current status. Background covers relevant history. Assessment includes vital signs, medications, labs, and concerns. Recommendation outlines planned interventions and what the receiving nurse must address, followed by a walk-around of all lines, pumps, and equipment. On exam questions involving shift change or unit transfer, bedside warm handoff using SPAR is the consistent right answer. Phone-only handoff, chart-only handoff, or skipping the walk-around all fall short of the standard because they reintroduce the information gaps that structured bedside handoff is designed to eliminate. Question 37. The nurse assesses a client recovering from open reduction and casting of a tibial fracture. The client reports severe pain unrelieved by opioids that worsens with passive toe extension. The foot is now pale and cool to touch. Which complication does the nurse suspect? Your options are A. Expected postoperative pain after surgery. B. Wound infection developing undercast. C. Compartment syndrome of the leg. D. Deep vein thrombosis behind knee. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Compartment syndrome of the leg. C is correct because the 5 P's of compartment syndrome include pain out of proportion worsened by passive stretch, pallor, paresthesia, paralysis, and pulselessness. Severe unrelieved pain with passive stretch worsening plus pallor signals rising intracompartmental pressure requiring urgent fasciotomy evaluation and cast bivalving immediately. A is wrong because expected postoperative pain responds to scheduled analgesia and improves with rest and elevation. Pain that escalates beyond opioid coverage and worsens with passive stretch represents pathology rather than the normal trajectory of orthopedic recovery. B is wrong because a cast-related wound infection typically produces fever, foul drainage, warmth, and a sweetish odor under the cast. The dominant feature here is severe ischemic type pain with pallor, pointing to a vascular emergency. D is wrong because deep vein thrombosis usually presents with calf swelling, warmth, and aching pain rather than pallor or pain worsened by passive stretch. The neurovascular pattern matches compartmental pressure, not venous obstruction. Compartment syndrome occurs when pressure builds inside a closed fascial compartment, cutting off perfusion to the muscles and nerves trapped inside. Because fascia cannot stretch, even a small increase in volume causes a rapid, dangerous rise in pressure. The venous outflow is occluded first as pressure rises, then arterial inflow fails. Without blood supply, muscle and nerve tissue become ischemic and can infarct within hours if the pressure is not relieved. The most common triggers are fractures of the tibia and forearm, crush injuries, tight casts or constrictive dressing, vascular injury, and reperfusion edema after revascularization of an ischemic limb. The 5 Ps describe the clinical presentation in order of appearance. Pain out of proportion to the injury and worsened by passive stretch is the earliest and most reliable sign. Pulselessness is the last and most ominous finding. Waiting for it means irreversible damage has likely already occurred. While awaiting surgery, split or bivalve any constrictive cast and elevate the limb to heart level only, not above, as that would reduce arterial inflow. Definitive treatment is fasciotomy, the surgical opening of the fascia to release pressure and restore perfusion within the 4 to 8 hour window before permanent injury. Question 38. The nurse is preparing a client for a computed tomography scan with iodinated contrast. The client reports a prior reaction described as hives after contrast administration last year. Which action by the nurse is most appropriate before the procedure today? Your options are: A. Notify prescriber. Discuss pre-medication options. B. Document allergy and proceed cautiously. C. Withhold all oral intake for 24 hours. D. Administer a beta blocker pre-procedure. Which would you go with? Lock it in before the reveal. The correct answer is A. Notify prescriber. Discuss pre-medication options. A is correct because a documented iodinated contrast hypersensitivity warrants prescriber discussion of corticosteroid and antihistamine pre-medication or alternative imaging. The team weighs benefit against risk, plans intra-procedure monitoring, and identifies emergency interventions including epinephrine should anaphylaxis develop during scanning. B is wrong because documentation alone does not prevent a repeat reaction in a client with prior contrast hypersensitivity. The client needs corticosteroid and antihistamine pre-medication or alternative imaging, not merely a chart note and caution. C is wrong because a 24-hour fast is excessive and unnecessary for contrast scanning. Standard preparation involves a short fast or none, with hydration to support renal clearance rather than prolonged restriction of intake. D is wrong because beta blockers do not prevent contrast hypersensitivity and may worsen outcomes by blunting epinephrine response if anaphylaxis develops. Pre-medication for prior reactions uses corticosteroids and antihistamines rather than beta blockade. When a client has a documented prior reaction to iodinated contrast, that history fundamentally changes how the imaging team plans the procedure. Understanding why requires knowing what these reactions are and how they work. Reactions exist on a spectrum. Mild reactions like warmth and metallic taste are common. Moderate reactions include hives and urticaria. Severe reactions of bronchospasm, laryngeal edema, and circulatory collapse are rare but life-threatening. Critically, the severity of a past reaction does not reliably predict the severity of a future one. These reactions are classified as anaphylactoid because mast cell activation occurs without classic IgE mediation. Despite the different mechanism, the clinical presentation is indistinguishable from true anaphylaxis, which is why prior history must always be reported before any contrast study. The standard pre-medication regimen includes oral prednisone 50 mg at 13, 7, and 1 hour before contrast, plus diphenhydramine 50 mg 1 hour before. This dampens mast cell activation and histamine release before the trigger arrives, substantially reducing but not eliminating repeat reaction risk. Management depends on prior reaction severity. Mild to moderate history triggers the pre-medication protocol. Severe prior reactions prompt consideration of MRI or ultrasound instead. In every case, the nurse's essential action is to notify both the prescriber and the radiologist so the team can decide together. 1. Proceeding without that notification is never the right pathway. Question 39. The nurse is preparing a client for magnetic resonance imaging of the brain. During the pre-procedure interview, the client reports a pacemaker that is not labeled as magnetic resonance imaging conditional. Which action by the nurse is most appropriate? Your options are: A. Proceed because most pacemakers are safe. B. Remove the pacemaker before the scan. C. Place a lead shield over the device. D. Stop the process, notify radiology team. Don't overthink it. Which one feels right? The correct answer is D. Stop the process, notify radiology team. D is correct because a pacemaker not labeled magnetic resonance imaging conditional is an absolute contraindication because the magnetic field can heat the device, dislodge leads, or trigger inappropriate pacing. The nurse stops the process and notifies radiology to coordinate alternative imaging with cardiology. A is wrong because routine safety applies only to devices specifically certified as magnetic resonance imaging conditional. Pacemakers without that designation can be heated, reprogrammed, or damaged within the strong magnetic field generated by the scanner. B is wrong because removing a pacemaker is a surgical procedure with substantial risk and is never undertaken to enable elective imaging. The appropriate path is alternative imaging coordinated with cardiology before any scan proceeds. C is wrong because lead shielding does not block the magnetic field that drives magnetic resonance imaging. Such shields apply to ionizing radiation, while magnetic interactions require full device compatibility rather than passive shielding around the device. Magnetic resonance imaging uses an extraordinarily powerful magnetic field that is always on, extending well beyond the scanner bore. Understanding why certain implants create life-threatening risks requires knowing how that field interacts with metal and electronics inside the body. 3 distinct mechanisms drive MRI danger. Ferromagnetic objects are pulled toward the magnet with tremendous force. Conductive leads absorb radio frequency energy and heat, causing tissue burns. And programmable devices like pacemakers can be reprogrammed or triggered into dangerous rhythms by the electromagnetic environment. Devices fall into 3 official categories. MRI safe means no known hazards for any MRI environment. MRI conditional means safe only under the manufacturer's defined conditions: field strength, scan duration, location. MRI unsafe includes all ferromagnetic devices and any pacemaker not certified for the scanner. An unlabeled device is always treated as unsafe until proven otherwise. The pre-procedure interview is the safety gatekeeper. The nurse must ask about every implanted device, prior metallic implants, and any history of metal fragments near the eyes. A non-conditional pacemaker is an absolute contraindication. Each unresolved positive answer stops the procedure. hold, notify the prescriber and radiologist, and arrange an alternative. The priority nursing action is always to hold the procedure and notify the team. Conditional does not mean unconditional. Conditions must be verified. Proceeding without confirmed labeling is the error that harms patients. Question 40. Over 4 hours, a post-operative client's heart rate trends from 88 to 102 to 116 to 128, while blood pressure trends from 128/76 down to 96/60, with declining urine output. Which interpretation by the nurse is correct? Your options are A. Stable recovery from surgery, B. Anticipated dehydration from fasting, C. Progressive shock requiring rapid response, D. Effective opioid analgesia at work. Got a guess? Lock it in. The correct answer is C. Progressive shock requiring rapid response. C is correct because a rising heart rate paired with falling pressure and declining urine output reflects progression from compensated to decompensated shock. The nurse activates the rapid response team, assesses dressings and drains for hemorrhage, ensures large bore access, and prepares blood products. A is wrong because progressive tachycardia, falling pressure, and declining urine output represent active deterioration rather than stable recovery. Mistaking this picture for normal healing would delay the rescue measures the trajectory clearly demands at this hour. B is wrong because dehydration from preoperative fasting tends to produce mild tachycardia and orthostatic changes that respond to maintenance fluids. The dramatic continuous trend described exceeds simple volume depletion and points toward acute hemorrhage instead. D is wrong because effective opioid analgesia generally slows the heart and respiratory rates without driving progressive hypotension and oliguria. The deterioration pattern shown is incompatible with appropriate analgesic effect during routine post-operative recovery. Shock isn't defined by low blood pressure. It's defined by inadequate tissue perfusion. The body fights hard to compensate before vital signs ever look alarming, which is exactly why a single normal reading can be dangerously misleading. During compensated shock, sympathetic activation drives tachycardia, peripheral vasoconstriction, and blood redistribution toward the brain and heart. The nurse who watches trends will spot the earliest signs: a climbing heart rate, dropping urine output, subtle mental status changes, and cool peripheral skin, all before blood pressure budges. Decompensation begins when the body can no longer keep up. Blood pressure finally drops. Urine output falls below 30 milliliters per hour. Mental status deteriorates from anxiety toward obtundation. Skin turns cold and mottled, and rising lactate signals anaerobic metabolism. End organ damage accumulates rapidly from this point forward. All 4 shock categories share one common thread. Blood pressure drops late, after compensation has already failed. Hypovolemic shock shows low filling pressures. Cardiogenic shows high filling pressures. Distributive shock presents with warm vasodilated skin, and obstructive shock carries specific physical findings like muffled heart sounds or absent breath sounds. The clinical takeaway is simple but critical. Vital signs must be trended, not just checked once. A rising heart rate, falling urine output, and declining mental status across hours is the signature of decompensation in progress. Recognize the pattern early and escalate immediately. Waiting costs the window for reversal. Question 41. The nurse is educating the parents of a 6-week-old infant about safe sleep to reduce sudden infant death syndrome. The mother describes family co-sleeping traditions and asks how to balance them with safety. Which statement by the mother indicates correct understanding? Your options are: A. Soft pillows will cushion the baby. But I share my bed for breastfeeding. C. Stomach sleeping prevents choking. D. Firm mattress with no loose items. Which one is it? Pause the video if you need more time. The correct answer is D. Firm mattress with no loose items. D is correct because a firm flat mattress, a tight-fitting sheet, and an empty crib free of bumpers, pillows, blankets, and toys is the American Academy of Pediatrics standard for sudden infant death syndrome prevention. Room sharing without bed sharing is also recommended. A is wrong because soft pillows of any size or placement increase the risk of suffocation and rebreathing. The crib should be empty aside from the fitted sheet, regardless of how reassuring the soft surroundings may appear to adults. B is wrong because bed sharing is a well-documented sudden infant death syndrome risk factor. Room sharing on a separate firm sleep surface allows easy breastfeeding access without the suffocation and entrapment hazards of an adult mattress. C is wrong because prone sleeping is the single largest modifiable sudden infant death syndrome risk factor. Healthy infants are placed supine to sleep, and the gag reflex protects them from choking even after spitting up. Sudden infant death syndrome remains a leading cause of post-neonatal mortality in the United States. Decades of research have identified specific, modifiable factors that nurses teach every new parent to reduce risk substantially. The American Academy of Pediatrics bundles 4 core recommendations: supine sleep every time, a firm flat mattress with a fitted sheet as the only soft surface, room sharing without bed sharing for at least 6 months, and additional protective factors like pacifier use and avoiding smoke. Visually, the safe sleep space is a firm, flat, uncluttered crib or bassinet. Nothing soft belongs inside. No bumpers, no blankets, no positioners. The crib sits in the parent's room, keeping the infant close without sharing a sleep surface. The Back to Sleep campaign, launched in 1994, cut SIDS rates by more than 50%. Supine positioning works through 3 mechanisms. It reduces rebreathing of exhaled carbon dioxide, preserves normal arousal responses during sleep, and lowers the risk of suffocation from soft bedding. 2 common confusables. Mild reflux does not change the recommendation. Supine is still safest. And once an infant can roll independently in both directions, parents place them supine and allow self-positioning. The full safe sleep bundle is always the correct answer. Question 42. The nurse is teaching a 35-year-old woman with no abnormal cervical screening history, no immunocompromise, and 1 lifetime sexual partner about cervical cancer screening. The client asks how often screening should occur. Which schedule should the nurse describe as currently acceptable? Your options are A. Annual PAP starting at age 18. B. PAP every 3 years or co-test. C. No screening needed at any age. D. Annual PAP then stop at 30. Take a second. Which answer would you pick? The correct answer is B. PAP every 3 years or co-test. B is correct because women aged 30 to 65 without risk factors may choose PAP testing every 3 years, PAP with human papillomavirus co-testing every 5 years, or primary human papillomavirus testing every 5 years. All 3 options are currently endorsed. A is wrong because cervical cancer screening begins at age 21, not 18, and annual PAP tests have been replaced by longer intervals for low-risk women. Excess screening detects transient human papillomavirus changes without improving outcomes. C is wrong because skipping screening entirely misses precancerous lesions that are highly treatable when caught early. Cervical cancer remains a leading cancer killer worldwide where screening programs are absent or interrupted by lapses in coverage. D is wrong because age 30 is where screening intervals lengthen, not where screening ends. Average risk women may discontinue screening at age 65 only after adequate prior negative results within the recommended testing windows. Cervical cancer screening guidelines have evolved significantly, moving away from annual pap tests toward longer, evidence-based intervals that reduce overtreatment without missing true disease. Understanding the logic behind these intervals is essential for nursing practice. The recommended approach depends primarily on age. Women under 21 are not screened at all, because HPV-related lesions in that group typically regress on their own. Screening ends at 65 for women with adequate prior negative results. For women aged 30 to 65 with no risk factors, 3 options are equally acceptable: a pap test every 3 years, co-testing with pap plus HPV every 5 years, or primary HPV testing every 5 years. All 3 provide equivalent cancer risk reduction. The longer 5-year interval is justified by HPV's natural history. Most infections clear spontaneously within 1 to 2 years, so frequent testing would flag transient infections unnecessarily. Only persistent high-risk HPV drives the slow progression through dysplasia to invasive cancer, a process that takes many years. Certain risk factors override the routine schedule. Immunocompromised women, those with a history of cervical dysplasia, and women with in utero DS exposure all require more frequent screening under tailored protocols. Importantly, HPV vaccination does not change the screening schedule, since the vaccine does not cover every high-risk type. Question 43. An older adult is admitted to the medical unit through the emergency department for new onset confusion and a culture-confirmed urinary tract infection. The receiving nurse is beginning the admission process at the bedside. Which action should the nurse implement first for this client? Your options are: A. Reconcile the home medication list. B. Orient the client to the room. C. Verify client using 2 identifiers. D. Begin head-to-toe physical assessment. Before I reveal it, which one do you think is right? The correct answer is C. Verify client using 2 identifiers. C is correct because verifying the client with 2 unique identifiers, such as full name and date of birth, must precede every admission step. Confirming identity first anchors all subsequent assessment findings, orders, and medication records to the correct chart and the correct person. A is wrong because medication reconciliation is a required admission task that follows identity verification. Reconciling for a wrongly identified client could pull the wrong home list into the chart and trigger downstream errors at every care transition. B is wrong because orientation supports comfort and call light use, yet it is a courtesy step rather than a safety prerequisite. Without confirmed identity, even orientation could be given to the wrong person on the unit. D is wrong because the head-to-toe assessment is the registered nurse's responsibility, but performing it on an unverified client attaches baseline findings to the wrong chart. Identity verification anchors every assessment finding to the correct medical record. The Joint Commission's first national patient safety goal requires 2 unique identifiers before any medication, procedure, blood transfusion, or sample collection. This rule applies at every encounter, but admission is the critical moment where the chain of identity is first established for the entire hospitalization. The 2 identifiers must distinguish this client from every other client. Full legal name, date of birth, and medical record number all qualify. Room number and diagnosis are never acceptable because neither is unique to the individual. At admission, the nurse uses open-ended phrasing, asking the client to state name and date of birth rather than confirm a yes or no prompt. The stated values are compared to the registration record, the wristband is printed and applied, and the match is confirmed before any care proceeds. When a client cannot provide identifiers due to confusion, sedation, or unconsciousness, Acceptable alternatives include family confirmation, a photograph in an existing record, or a temporary identifier such as John Doe with a uniquely assigned medical record number until identity is established. Skipping or delaying the two identifier step at admission undermines every subsequent intervention. Verifying full name and date of birth before vital signs, IV access, or chart review is always the correct first action. Question 44. A client with type 1 diabetes uses both regular insulin and intermediate-acting NPH and prefers a single injection at the evening dose. The nurse is mixing the two insulin preparations in one syringe. Which technique reflects correct mixing of these two insulins? Your options are A. Air NPH, air regular, clear first. B. Draw NPH first, then add regular. C. Mix only in a separate syringe. D. Shake both vials before drawing up. What's your answer? Commit to one before I continue. The correct answer is A. Air NPH, air regular, clear first. A is correct because the nurse injects air into the cloudy NPH vial, then air into the clear regular vial, then draws regular insulin first, followed by NPH. The clear before cloudy sequence prevents contamination of the regular insulin vial with longer acting NPH suspension during preparation. B is wrong because drawing NPH first contaminates the regular insulin vial when the syringe returns. NPH suspension would shorten or unpredictably alter the action profile of any regular insulin pulled later from that vial during preparation. C is wrong because separate syringes negate the purpose of the mixing technique and require an extra needle stick. Regular and NPH insulin are designed to be combined safely in a single syringe when proper sequencing is followed. D is wrong because shaking insulin vials denatures the protein and creates foaming that affects dose measurement accuracy. The cloudy NPH is gently rolled between the palms, while clear regular insulin requires no agitation at all. When a client needs both regular and NPH insulin, a nurse can combine them into a single syringe, reducing daily injections and improving adherence. The procedure follows a strict sequence designed to prevent contamination between the two vials. NIH insulin is regular insulin bound to protamine zinc, which delays absorption. If protamine contaminates the regular insulin vial, it can permanently convert that vial's contents to a slower acting form, altering the pharmacokinetics of every dose drawn from it afterward. The sequence has 4 steps. Inject air into the cloudy NPH vial first. Then inject air into the clear regular vial and immediately draw up the regular dose. And finally draw up the NPH dose. Air is injected into NPH first to maintain pressure, and regular is always drawn before NPH to stay uncontaminated. Visualize the two vials side by side. The cloudy NPH vial receives the first air injection to equalize pressure, but no insulin is drawn yet. The clear regular vial receives air next, and regular insulin is drawn immediately. NPH is always drawn last into the same syringe, completing the total prescribed volume. The mnemonic clear before cloudy locks in the correct draw order. Note that long-acting insulins like Glargine are never mixed due to pH incompatibility, and pre-mixed products skip this step entirely. This rule applies specifically to NPH and regular insulin combined at the bedside. Question 45. The nurse is preparing an intramuscular injection for a healthy adult who requires a large volume antibiotic. The prescriber's order allows up to 3 milliliters and the client has no site contraindications. Which intramuscular site is most appropriate for the nurse to select? Your options are A. Dorsogluteal near the buttock crease, B. Ventrogluteal on the lateral hip, C. Deltoid in the upper arm, D. Vastus lateralis at the outer thigh. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B, ventrogluteal on the lateral hip. B is correct because the ventrogluteal site is the preferred intramuscular location in adults because it is free of major nerves and blood vessels, has consistent muscle thickness, and safely accommodates up to 3 milliliters. The V method landmarking ensures accurate placement. A is wrong because the dorsogluteal site carries risk of sciatic nerve injury and inconsistent absorption from overlying subcutaneous fat. Current best practice has moved away from the site in favor of the ventrogluteal injection for adults. C is wrong because the deltoid is limited to about 1 to 2 milliliters in adults and is best suited for vaccines and small volume injections. A 3 milliliter antibiotic order would exceed the safe deltoid limit. D is wrong because the vastus lateralis is the preferred site mainly for infants under 12 months. In healthy adults it is acceptable, but the ventrogluteal site is the first choice recommendation for routine intramuscular injections. Intramuscular injections deliver medication deep into muscle tissue, where rich blood supply enables rapid absorption. Choosing the right site depends on the patient's age, the volume being injected, and the medication itself. Adult clinical practice recognizes 4 primary sites. The ventrogluteal is now the preferred site for large volume injections, while the dorsogluteal has largely fallen out of favor due to proximity to the sciatic nerve and superior gluteal artery. The ventrogluteal site is located using 3 bony landmarks: the greater trochanter, the anterior superior iliac spine, and the iliac crest. The injection goes into the V formed between the index and middle fingers, targeting the gluteus medius and minimus, a zone free of major nerves and vessels. Match the site to the patient. The ventrogluteal handles up to 3 milliliters in adults. The vastus lateralis is preferred for infants and young children whose gluteal muscles are underdeveloped. The deltoid is reserved for small volumes like vaccines, generally no more than 1 milliliter. When the question describes a healthy adult requiring a large volume intramuscular injection, the ventrogluteal site is the consistent answer. Matching site to age, volume, and medication is the core discipline. Question 4X. The nurse performs a focused cardiac assessment on a 68-year-old client admitted for fluid overload. The nurse auscultates an S3 gallop at the apex and notes bilateral pitting edema with jugular venous distension. Which interpretation by the nurse is most accurate? Your options are A. Volume overload from heart failure, B. Normal cardiovascular adaptation to aging, C. Acute pericardial effusion with tamponade, D. Pulmonary embolism with right strain. Which would you go with? Lock it in before the reveal. The correct answer is A. Volume overload from heart failure. A is correct because an S3 gallop in an adult signals rapid ventricular filling against an overdistended chamber, classically associated with heart failure, combined with jugular venous distension and pitting edema. The picture reflects systemic congestion, warranting diuresis and prescriber notification. B is wrong because an S3 in adults is abnormal, regardless of advancing age. The combination of an abnormal heart sound with congestion findings goes well beyond age-related changes, such as a stiffer ventricle or softer first heart sound. C is wrong because cardiac tamponade typically produces muffled heart sounds. Hypertension and pulsus paradoxus, the Beck triad. The presence of an S3 gallop and dependent edema points away from acute effusion and toward chronic congestion. D is wrong because pulmonary embolism is dominated by sudden dyspnea, pleuritic chest pain, tachycardia, and hypoxia. Bilateral pitting edema and an apical S3 gallop do not fit the right heart strain pattern of pulmonary vascular obstruction. Beyond the two normal heart sounds, extra sounds called gallops reveal important pathology. Understanding when and why S3 and S4 appear helps you identify conditions like heart failure at the bedside. S1 and S2 mark the boundaries of systole and diastole. S3 occurs early in diastole, right after S2, produced by rapid filling against an overdistended ventricle. S4 occurs late in diastole, just before S1, when the atrium contracts against a stiff chamber. The S3 gallop is low-pitched and best heard at the apex using the bell of the stethoscope, with the client in the left lateral decubitus position. In adults over 40, S3 almost always indicates pathologic volume overload, most commonly from congestive heart failure. S3 rarely appears alone. The full heart failure cluster includes jugular venous distension, basilar crackles, and peripheral edema. When these findings appear together on the exam, heart failure is the answer. S3 follows S2 and reflects a dilated, volume-overloaded ventricle, classically heart failure. S4 precedes S1 and reflects a stiff, but not necessarily dilated ventricle, as seen in hypertensive heart disease or hypertrophic cardiomyopathy. Timing relative to S1 and S2 is everything. Question 47. The nurse reviews an order that reads digoxin 0.5 milligrams orally once daily. The client is alert. The most recent potassium is normal and the prescriber is reachable by phone. Which action by the nurse best applies Institute for Safe Medication Practices? Do not use abbreviation principles. Your options are: A. Administer 5/10 milligram as written. B. Round the dose up to 1 milligram. C. Clarify the order, add leading 0. D. Hold digoxin, document client refusal. Don't overthink it. Which one feels right? The correct answer is C. Clarify the order, add leading 0. C is correct because doses below 1 require a leading 0 to highlight the decimal point. The nurse contacts the prescriber to clarify the order so it reads 0.5 milligrams. Missing leading zeros have caused tenfold overdoses when the decimal was overlooked. A is wrong because accepting an order without a leading 0 perpetuates a writing style on the Institute for Safe Medication Practices do not use list. Later readers could overlook the decimal point and administer 5 milligrams, a dangerous overdose. B is wrong because rounding up to a higher dose without prescriber authorization changes the medication order itself. Digoxin has a narrow therapeutic index, so even a small upward adjustment could push the client into the toxic range. D is wrong because holding the medication without contacting the prescriber leaves a needed cardiac drug unadministered. The correct action is order clarification rather than assuming the client refuses, or that the drug should simply be skipped. Decimal point errors in medication orders are among the most dangerous writing mistakes in clinical practice. 2 simple rules. The leading 0 and the trailing 0 exist to prevent tenfold dosing errors that have caused serious patient harm. The leading 0 rule requires a 0 before any decimal point when the dose is less than 1. The trailing 0 rule forbids adding a decimal and 0 after a whole number. Both rules eliminate the ambiguity that causes a reader to misinterpret the decimal point's position. Tenfold errors are most dangerous with high alert medications including opioids, anticoagulants, insulin, digoxin, and levothyroxine, drugs with narrow therapeutic windows where a tenfold overdose can be immediately life-threatening. A missing leading 0 makes 0.5 look like 5, a tenfold overdose. A trailing 0 after a whole number makes 5.0 look like 50, also a tenfold overdose. The decimal point disappears visually under time pressure, and the written digit is all the reader sees. When a nurse identifies a leading or trailing 0 violation, the correct action is to hold the dose. Contact the prescriber for clarification. and administer only after the order is corrected in the record. The order is treated as ambiguous, never as a directive to give the literal amount written. Question 48. A client with a documented peanut allergy is admitted for worsening abdominal pain. 10 minutes after a new intravenous antibiotic begins. The client reports throat tightness. The nurse notes hives across the chest, audible stridor, and blood pressure of 80/50. Which action should the nurse take first? Your options are A. Stop infusion, prepare IM epinephrine. B. Give diphenhydramine intravenously for hives. C. Low head of bed, apply oxygen. D. Page prescriber, document the reaction. Got a guess? Lock it in. The correct answer is A. Stop infusion, prepare IM epinephrine. A is correct because anaphylaxis requires stopping the trigger first and administering intramuscular epinephrine into the vastus lateralis as the first-line drug. Antihistamines, corticosteroids, and bronchodilators are adjuncts that follow epinephrine and never replace it during the initial emergency response. B is wrong because diphenhydramine is an H1 blocker adjunct that does not reverse the laryngeal edema or shock-driving anaphylaxis. Giving an antihistamine first delays the only drug proven to halt the reaction, which is epinephrine. C is wrong because lowering the head of the bed without addressing the trigger does nothing to interrupt the systemic reaction. Positioning has a role only after epinephrine. Stopping the infusion and giving the drug come first. D is wrong because paging and documenting are necessary but secondary tasks during anaphylaxis. The first action belongs to the bedside nurse, who must stop the trigger and treat the airway and circulatory threat immediately. Anaphylaxis is a life-threatening systemic allergic reaction that can cause airway collapse and circulatory failure within minutes. Understanding the underlying mechanism explains why every first action matters and why the sequence cannot be reversed. When a sensitized person encounters a trigger, IgE antibodies activate mast cells, which release histamine and other mediators simultaneously. This floods the body with signals that dilate blood vessels, constrict airways, swell mucosal tissue, and produce the characteristic skin findings all at once. The two first actions happen simultaneously. Stop the trigger to limit ongoing antigen exposure and give intramuscular epinephrine. The injection site of choice is the vastus lateralis because absorption there is faster than the deltoid, making it critical to specify the site correctly. Epinephrine works at every level of the cascade simultaneously. No antihistamine, corticosteroid, or fluid bolus can replicate this. Adjuncts like diphenhydramine, famotidine, corticosteroids, and albuterol follow epinephrine but never replace it as the first action. Whenever the clinical picture shows known allergy, urticaria, bronchospasm, and hypotension together, the answer is always the same. Stop the trigger and give intramuscular epinephrine into the vastus lateralis. Anything that comes before that step is wrong. Question 49. The nurse is teaching a 52-year-old woman about colorectal cancer screening. The client is asymptomatic, has no personal or family history of colon cancer, and recently lost insurance coverage. Which client statement indicates correct understanding of current average risk screening guidance? Your options are A. Screening should begin at age 30. B. I should stop screening at age 50. C. Colonoscopy every 10 years is acceptable. D. Screen only when I feel ill. Which one is it? Pause the video if you need more time. The correct answer is C. Colonoscopy every 10 years is acceptable. C is correct because The United States Preventive Services Task Force and American Cancer Society recommend starting colorectal cancer screening at age 45 for average risk adults. Options include colonoscopy every 10 years, annual fecal immunochemical testing, or stool DNA testing every 3 years. A is wrong because routine colorectal cancer screening for average risk adults begins at age 45, not 30. Screening before 45 is reserved for clients with familial syndromes, inflammatory bowel disease, or significant family history of colon cancer. B is wrong because age 50 is no longer a stopping point and now sits 5 years past the recommended starting age. Screening typically continues through age 75, with individualized decisions for clients between 76 and 85. D is wrong because waiting for symptoms defeats the purpose of secondary prevention. Most colorectal cancers are clinically silent until late stages, and screening identifies precancerous polyps long before any symptoms appear in the client. Colorectal cancer is the second leading cause of cancer death in the United States, yet it's one of the most preventable cancers through screening. In 2021, the USPSTF lowered the recommended starting age for average risk adults from 50 to 45, driven by rising rates of colorectal cancer in younger people. Average risk adults, those without inflammatory bowel disease, Lynch syndrome, familial adenomatous polyposis, or a significant family history, begin screening at 45 and continue through age 75. After 75, the decision is individualized based on health and prior screening history. Several modalities are accepted. Colonoscopy every 10 years is the gold standard because it visualizes the entire colon and allows polyp removal. Annual fecal immunochemical testing is a low-cost, less invasive alternative. Multi-target stool DNA testing is done every 3 years, and CT colonography every 5 years is another option. Screening works by catching adenomatous polyps before they progress to invasive cancer, and by detecting early cancers while they are still highly curable. Removing a polyp during colonoscopy breaks the progression entirely. High-risk groups follow tailored earlier protocols. Lynch syndrome carriers begin colonoscopy in their 20s. FAP carriers begin sigmoidoscopy in adolescence. And patients with long-standing inflammatory bowel disease start surveillance 8 years after onset. A first-degree relative diagnosed before 60 triggers screening at age 40 or 10 years before that diagnosis, whichever comes first. Question 50. The nurse is caring for a postpartum client who delivered vaginally 3 weeks ago. The client now reports persistent sadness, inability to bond with the baby, sleep disturbance, and states, "The baby would be better off without me." Which action by the nurse is the priority? Your options are: A. Recommend sleeping when baby sleeps. B. Refer to a support group later. C. Reassure that baby blues are normal. D. Conduct immediate safety assessment. Take a second. Which answer would you pick? The correct answer is D. Conduct immediate safety assessment. D is correct because a statement that the baby would be better off without me is a classic warning sign of suicidal or infanticidal ideation in postpartum depression or psychosis. Immediate safety assessment overrides routine education or referral at this point. A is wrong because suggesting more sleep dismisses a life-threatening cue. The client's expressed thought of being a burden indicates a psychiatric emergency that cannot be addressed by sleep hygiene advice for routine postpartum fatigue. B is wrong because a support group referral works on a timeline of days to weeks, which is far too slow for current ideation. Acute safety planning and same-day evaluation must occur before any outpatient follow-up is scheduled. C is wrong because baby blues resolve within 2 weeks and never include thoughts of suicide or infant harm. Mislabeling the disclosure as a normal phase delays evaluation and could be catastrophic for the mother and the newborn. Postpartum mood disturbances exist on a spectrum, and distinguishing among them is one of the most consequential judgments in postpartum nursing. Because the correct response depends entirely on which condition you're dealing with. The three conditions are baby blues, postpartum depression, and postpartum psychosis. Baby blues resolve within 2 weeks and lack harm ideation. Postpartum depression persists beyond 2 weeks and can include thoughts of self-harm. Postpartum psychosis involves hallucinations and delusions and is an immediate psychiatric emergency. 4 features separate the conditions: timing relative to the 2-week mark, severity, symptom content, particularly whether hallucinations or delusions are present, and the presence of suicidal or infanticidal ideation. Baby blues affect up to 80% of women and resolve spontaneously. Postpartum depression affects 10 to 15% and requires psychotherapy or antidepressants. Postpartum psychosis, occurring in roughly 1 to 2 per thousand deliveries, demands immediate inpatient psychiatric admission. Any statement suggesting the baby would be better off without her, or that she should not be here, is a red flag requiring an immediate focused safety assessment, not reassurance. Ensuring mother and infant safety and arranging same-day psychiatric evaluation are the priority actions.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.